Hello everyone. Am I visible and audible to you people? Good morning to all of you. Kindly someone confirm visibility audibility is great in the chat box so I can start ahead. Are you people there? Am I visible, audible? Okay, thank you. Thanks a lot those who have confirmed. So a very good morning to all of you. I welcome you all for today's session. I am Dr. Priyanka and today I am going to continue a topic from systemic pathology. Those who are continuing since last two lectures, they know I am continuing with cardiovascular system CVS. We have already taken 2 lectures of this free batch. So I am continuing with the 3rd lecture today. And this lecture is highly useful for the aspirants of NEET PG, FMGE, CET for all competitive exams basically, and also specifically for second prof MBBS students, because I am going to continue this topic with theory, comprehensive theory, as well as I will cover with all MCQs in the past previous years which are asked in these competitive exams. So I'm just starting it without wasting time. In the last lecture, we have started endocarditis, but we have not finished it yet. So in the first 5 minutes, I will give a brief revision or review of the endocarditis, which I have taught in the last lecture. So those who are the newcomers, they will have a brief review about what topic we are continuing with. So in endocarditis, endocardium is the innermost layer. I'm just starting it. Are you people there? Should I start? Okay. So endocarditis, itis. In pathology, itis means inflammation. Endocarditis means inflammation of the endocardium. Endocardium is the innermost layer of the heart. So heart have basically 3 layers. These are the 4 chambers of the heart. These are the 3 layers of the heart you can see. The innermost layer is the endocardium, which I have drawn with red color. The middle layer is the myocardium, which I have drawn here with black color. And the outermost layer is the pericardium, which I have drawn here with sky blue color. So endocarditis I am teaching particularly now. We will continue with myocarditis and pericarditis also later on in this lecture only. But right now I am continuing with endocarditis. Endocarditis is the most important topic for theory as well as MCQs. Now basically I want to highlight one thing here. Can you see I have drawn here 2 walls with purple color? This one. I have drawn the walls, mitral wall and tricuspid wall. Basically, all the heart walls are also made up of endocardium. So endocardium is of 2 types. The endocardium present over the wall is known as valvular endocardium. And the endocardium which is present at rest of the heart, apart from wall, is known as mural endocardium. So in endocarditis, all types of endocarditis we are teaching now. In endocarditis, basically valvular endocardium is more important because over the walls of the heart, vegetations are formed and that vegetations cause deformity in the walls. Deformity. So walls have 2 types of deformities. Either there will be regurgitation or there will be stenosis. So different diseases will have different manifestations. So endocardium is of 2 types: valvular endocardium present over the heart walls and mural endocardium present except from walls. Apart from walls, the rest of the heart have mural endocardium. So endocarditis, in the last lecture we have already covered rheumatic endocarditis. Not only endocarditis, we have covered rheumatic pericarditis, because in rheumatic fever or rheumatic heart disease there is pericarditis. That is, all 3 layers are involved: endocardium also, myocardium also, pericardium also. So when all 3 layers are involved, it is known as pericarditis. Pen means all layers are involved. So endocarditis we have also covered. Today I am going to cover this topic with non-rheumatic endocarditis, in which I am going to teach you 3 more types of endocarditis. That is Libman-Sek endocarditis in SLE, NBTE, non-bacterial thrombotic endocarditis, and infective or bacterial endocarditis. So these 3 endocarditis which we will cover today. But first I will give you a brief revision of rheumatic endocarditis. So we will have a comparative study of the rest of the 3. If I start directly from rest of the 3, those who are newcomers, they won't know what is there in rheumatic endocarditis. So first I will give, in the first 5 minutes, I will give 5 or 10 minutes, I will give you a brief revision of rheumatic endocarditis so that we will have a comparison of rest of the 3 endocarditis. Then rest of the 3 endocarditis we will take in detail, like rheumatic only. So are you people there? Have you got it what I have said? So I will give you a brief review of rheumatic first in the first 5 minutes. Then we will start the rest of the topics. So these are the 4 types of endocarditis. I will read this table in the end for you when I will cover all 4. So first I am giving you a brief revision of rheumatic fever and rheumatic endocarditis. You already know what is rheumatic fever. What is, I have told you a story yesterday. Na? Those who are the old students, they already know the story. So what is there? This is a child you can see. You can see this is a child here, and child is having pharyngitis, tonsillitis by group A beta streptococcal pharyngitis. So this is a bacteria which is causing tonsillitis or pharyngitis in the child. Correct or not? So child is forming antibodies against the bacteria, and these antibodies are neutralizing the bacteria. Antigen antibody reaction is taking place. Okay, but these antibodies are auto antibodies. So on 5 organs of the child, what are the 5 organs? Number 1 is heart, number 2 is brain, number 3 is skin. Just below the skin there is subcutaneous tissue below the skin, and there are joints. So these are the 5 organs. On these 5 organs, same antigen is present as that of bacteria. So these antibodies will react with these 5 organs also, because these are auto antibodies. So you can see in the diagram I have drawn, the antibodies are reacting with these 5 organs and causing diseases in these 5 organs. So what are the name of diseases in these 5 organs? In the heart, it is rheumatic heart disease. In the brain, it is syndrome scoria. In the skin, it is erythema marginatum. In the subcutaneous tissue, it is subcutaneous nodules. And in the joints, it is migratory polyarthritis. We have covered all these in the last lecture. And together, all these 5 diseases are known as rheumatic fever. So rheumatic fever is not single disease. It is an umbrella term which contains 5 diseases. And it usually occurs in child's 5 to 15 years. So these are the 5 diseases which we have already covered in the last lecture. So we know, I'm not reading it again. So I have given a brief review what is happening here. So we can say, what is the pathogenesis of rheumatic fever? It is molecular mimicry and cross-reactivity. What is molecular mimicry here? All these 5 organs, heart, brain, skin, subcutaneous tissue and joints, they have antigen which is similar to that of bacteria. So these 5 organs are doing mimicry of the bacteria, we can say. So that is known as molecular mimicry. And because of this molecular mimicry, the antibodies are doing cross-reaction. The antibodies are supposed to react with the bacteria only. But apart from reacting with bacteria, these antibodies are also reacting with these 5 organs. So that is known as cross-reactivity. So what is the mechanism? The mechanism is known as molecular mimicry, shown by the 5 organs of the body, and cross-reactivity shown by the autoantibodies. So in short, this is the mechanism. And Jones criteria, these 5 diseases together is known as Jones major criteria. Jones major, there are 5 major, 5 minor and 3 supportive criteria. We have already discussed in detail. So these are the 5 major criteria, the 5 diseases caused by them. So in the heart, it is RHD, rheumatic heart disease, which is pericarditis. In the brain, it is syndrome scoria. In the skin, erythema marginatum. In the subcutaneous tissue, subcutaneous nodules. And in the joints, migratory polyarthritis. So these are the 5 major criteria of Jones, along with this tonsillitis. Tonsillitis to hona hi chahiye. Correct or not? So these are the 5 major criteria which you must know. 5 minor criteria we have already discussed. You can read by your own. I'm not reading it again. Those who have old students, they already know. These are the 5 minor criteria and 3 supportive criteria. So 5 major, we know, 5 minor, we know, and 3 supportive. What are 3 supportive criteria? ये जो 5 major और 5 minor हैं, these are 5 major, these are 5 minor. अगर सिर्फ ये है तो we will not say it is rheumatic fever. Along with it, there is a history of pharyngitis. So history of pharyngitis is a supportive criteria. If without pharyngitis, these things are occurring only in a child, we won't label the child as rheumatic fever. We won't label. Apart from these 5 major, 5 minor, there should be pharyngitis by group A beta streptococcus bacteria. Then only we can say it is rheumatic fever. Otherwise, we won't say. So supportive criteria are gas criteria. Group A beta streptococcus. S for streptococcus, GAS. Group A streptococcus criteria, known as gas criteria. So there are 3 gas criteria. So there should be culture positive. So you will take a throat culture or pharyngeal culture that should be positive on a culture plate. You know, in microbiology, you have studied the culture properties of streptococcal bacteria, beta streptococcus bacteria. Yes or no? We will study that in microbiology also. So culture should be positive, number 1. And antibodies in blood should be positive for the bacteria. Which antibodies? Number 1, ASO, anti-streptolysin O, ASO antibodies. And number 2, anti-DNase antibody. Either of them should be positive. So that will prove that supportive criteria, that is pharyngitis, was there in the past 2-3 weeks before. So we have, these are known as revised Jones criteria. So either there should be 2 major out of the 5 major, or 1 major and 2 minor. Out of 5 major, 5 minor, 1 major and 2 minor. Either 2 major or 1 major, 2 minor, along with the supportive gas criteria. Gas criteria to hona hi chahiye. So then we will call it as rheumatic fever. So that was the summary till now. We have already covered the out of the 5 major criteria. The first, that is rheumatic heart disease. I'm not going to cover it completely. I will show you only one diagram in which I will give you the summary, and then I will come on non-rheumatic endocarditis, which is my topic for teaching today. This is the revision for the new students. Correct or not? Just to make the pace. Correct or not? So out of these 5, we have covered all these 5. The first one was in detail, that is rheumatic heart disease, in which there is pancarditis. Pancarditis means all the 3 layers are involved: endocarditis, myocarditis, pericarditis. So along with endocarditis, we have also studied myo and pericarditis. But my topic is endocarditis, but we have studied all 3: endocarditis, myocarditis, pericarditis, together known as pancarditis. Correct or not? So these are the 3 layers. In this diagram only, we will show all 3 deformities: endocarditis, myocarditis, pericarditis. You can see the 3 colors, the 3 layers. In endocardium also, you can see the 2 types of endocardium. The endocardium which is present over walls is known as valvular endocardium, and rest of the endocardium is known as mural endocardium. So what is the deformity? Who will tell me? So first we will talk about valvular endocardium. Endocardium में पहले valvular लेंगे, फिर mural लेंगे. So valvular में क्या होगा? Who will tell me? Those who have attended my last 2 lectures, they already know what is the deformity in valvular endocarditis. It is shown in the diagram only. There are vegetations over the wall. Yes. Ankit, Prabhakar, Udit, Deepak, you all are right. Okay, there are vegetations. Describe vegetations in 4 headings. Describe the gross. First, describe the gross. They are single, multiple, small, medium, large, firm, sterile, non-sterile. What they are? Describe their gross. Number 1. Number 2, describe the wall. Sequence of the 4 walls in which they are. I'm asking the questions first. Let me ask the questions. First, describe the gross. Describe their size. Describe their frequency. Describe their consistency. That is, they are small, medium, large, sterile, non-sterile. What are they? And they are single, multiple. Gross describe karo. Fir walls describe karo. The 4 walls in the heart. What is the sequence of involvement? Describe the walls. Then describe the location on the wall. Wall ke kis location pe hai exact. Then describe the location, and in the end describe the deformity. Always deformity. What deformity they cause? Always describe vegetations in these 4 headings. So we will take them one by one. First we will describe the gross. So they are, you all are correct. They are small, not medium, not large. I will tell you 3 more type of endocarditis today, in which 3 types of vegetations we will study. Some of them will be medium. Libman sac wala medium hoga. Some of them will be large. Bacterial endocarditis will be large, but this is small. So small, medium, large, it will come in your MCQ. So you have to take it correctly. Correct or not? They are multiple. They are not single. They are multiple. They are soft and firm, and they are sterile. There is no bacteria. I have told you the lesion is caused by antigen antibody reaction. It is caused by autoantibodies. It is not caused by bacteria. So that is gross. Gross to ho gaya. Come on the walls. Kaun si wall involved hogi? You can see the gross here. This is the first type of endocarditis. The rest 3 we have to study today. Correct or not? So this is the first one. You can see they are small. Compare the size of the first with rest of the 3. So the first one is small. So first one is small. The Libman sac will be medium, and rest 2 will be large. So this is small. Correct or not? And they are multiple. You can see. So these are small vegetations. You can see they are small. They are multiple. What is the sequence of the wall? Who will tell me? The sequence of the wall is this: mitral, followed by aortic, followed by tricuspid, followed by pulmonary. MATP. Yes, you all are correct. Dr. Gaurav, Sanjana. Yes, you are correct. Okay, Udit. Correct. So mitral, aortic, tricuspid, pulmonary. That is the sequence. So gross ho gaya, walls ho gaya. Now tell me the location on the wall. Exact location on the wall. Wall ke upar wale surface pe, ki niche wale surface pe, ki junction pe. Where it is, or all over. All over. So at the junction, don't say it junction, say it as line of closure. Yes, Sushma, you are right. Line of closure. Yes, Gaurav. Yes. So line, it is present over the line of closure. I have already explained. It is the line of closure. I have drawn it on my hands. Yes or no? And lastly, come on the deformity. What is the deformity? Name of the deformity? It is fish mouth or buttonhole appearance. So you can see it is looking like a fish mouth or buttonhole. Fish mouth or buttonhole, we have described it. So we are done with vegetations. We described the vegetations in 4 headings. What is their gross? What is the wall involvement? What is the location on the wall? What is the deformity? We are done. We are done with valvular endocarditis. Mural endocarditis, there is a patch. What is the name of the patch? It is McCallum patch in mural endocarditis. Where it is? See in which chamber it is. There are 4 chambers in the heart, 2 auricles, 2 ventricles. So where it is? It is in the auricle, not ventricle. Pehli baat to. Auricle में कौन सा? Left की right? It is in the left auricle. So it is present in the left auricle. Can you see this yellow color patch here? It is present in the left auricle just above the mitral wall on the posterior surface. Yes, you all are correct. I'm happy. Okay. So that is known as McCallum patch. So in this diagram, can you see I have shown vegetations also, McCallum patch also. So vegetations is there in the valvular endocardium and McCallum patch is there in the mural endocardium. So we are done with endocarditis. Endocarditis is done. Rheumatic endocarditis is done. Coming on myocardium. Myocardium mein kya hoga? You tell me. What will happen in myocardium? In myocardium, there will be Ashkoff bodies formation. Granuloma ban jayenge. So can you see the black colored dots I have shown? So you can see endocardium की दोनों चीजें तो दिखाई ही हैं इस डायग्राम में. It is shown endocardium में दो चीजें होंगी, mural में अलग, valvular में अलग. Myocardium में क्या होगा? What will happen in myocardium? In myocardium, multiple granulomas are formed. These granulomas are known as Ashkoff nodules. So can you see black colored dots I have drawn? So just tell me the structure. In Ashkoff nodule, you have to describe only one thing. Its structure. Its structure. Tell me the structure of Ashkoff nodule. So just I am zooming it out. So I'm zooming one of the nodule. Can you see? This is one of the nodule and I have zoomed it out. So this is structure of one of the nodule. All of them are like this only. I have drawn one. I have zoomed out one. So what is the structure? In the center, there is a necrosis. Can you see the yellow colored necrosis, which I'm highlighting with purple now? So this yellow colored necrosis in the center is fibrinoid necrosis. You know the 5 type of necrosis. Out of the 5 type, the 5th one, fibrinoid necrosis is present in the center. Say yes or no. So fibrinoid necrosis is present in the center. It is surrounded by 5 type of cells. I have drawn it with different colors. The 5 different colors, 5 type of cells. The red colored cells I have shown in the diagram. Look at the diagram. The red colored cells. They are multinucleated. They are multinucleated red colored cells. Giant cells. These are known as Ashkoff cells. Red color are multinucleated giant cells known as Ashkoff cells. The green colored are anti-Ashkoff cells. Green colored, the nucleus is caterpillar or owl-eye appearance, anti-Ashkoff. Apart from it, T NOR cells and plasma cells, lymphocytes and fibroblasts. There are no neutrophils. Please highlight it. Yes, both are modified macrophages, Sanjana. Correct. So this is the diagram, Ashkoff, anti-Ashkoff cells. We are done with myocarditis also. Coming on the last thing, pericardium. Pericardium mein kya hoga? Pericarditis. So in this diagram, you can see what will happen in pericarditis. Look at the outermost layer, green colored. I have drawn threads inside it. Can you see? I have drawn these threads. Thready, धागे जैसा हो गया है. So watery fluid की जगह, the fluid becomes thready. It becomes fibrinous. So there is fibrinous pericarditis. Because of these threads, it is looking like butter. 2 slices of a bread separated by butter. So butter, there is a sandwich of butter sandwich, 2 bread with butter in between. If we separate the 2 breads, we can see threads of the butter in between. So it is giving a bread and butter appearance. That is known as. So this is the master diagram. Just draw it. It is showing endocardial lesions also, myocardial lesions also pericardial lesions also. So endocardium में 2 चीजें होंगी, vegetations and McCallum patch. We are done. Myocardium में only one thing, Ashkoff nodules. The structure you have to describe. We are done. And pericardium में there is fibrinous pericarditis, bread and butter appearance. We are done. Give me a thumbs up if you got it. So this is the bread and butter. Appreciate the threads here. So pericardium and myocardium के बीच में threads are there. So that is bread and butter appearance. So finally we are done. So vegetations, McCallum patch, Ashkoff nodules, and fibrinous pericarditis, bread and butter appearance. So we are done. We are done with pancarditis. That was revision of the last lecture. I am continuing with rest of the 3 endocarditis. So we are done with the first endocarditis, which was the most important among these. That is rheumatic endocarditis. Now I will continue with non-rheumatic endocarditis. I will teach you these 3 one by one. First, I will take the first one, Libman-Sec endocarditis. So non-rheumatic endocarditis mein we will study 3 endocarditis. Libman-Sec endocarditis, which is the endocarditis caused by SLE, number 1. Number 2, NBTE, non-bacterial thrombotic endocarditis, which is seen in hypercoagulable state, number 2. And number 3, bacterial endocarditis or infective endocarditis, one and the same thing. Correct or not? So that is the 3rd. So these 3 together are known as non-rheumatic endocarditis. One was rheumatic. These 3 are non-rheumatic. Correct or not? So give me a thumbs up if you got it. Should I start? So first 15 minutes was the revision of the last lecture. Any doubt in the last lecture? Those who are newcomers, they have got the concept. Should we go ahead? Okay. So I'm starting with non-rheumatic endocarditis. No, जितनी बार कोई भी टॉपिक का you will revise it ना, you will have better understanding. इस बार rheumatic और थोड़ा ज़्यादा समझ में आया होगा और better समझ में आया होगा. So you have to revise the topic again and again by yourself. Yes or no? So I'm starting with non-rheumatic endocarditis. So I'm starting with the second one, that is Libman-Sec endocarditis. So starting with Libman-Sec endocarditis, also known as atypical verrucous endocarditis. Atypical verrucous endocarditis, also known as Libman-Sec endocarditis. Isme bhi the endocardium of the heart will be involved. Here there is no, it is seen in SLE. You know what is SLE? It is a collagen disease. Collagen disease in the body, especially seen in females. It is an autoimmune disease. In this, heart is involved. Many organs are involved. Here in SLE, body will form autoantibodies against DNA. No, DNA is present in the nucleus of all cells of the body. No? So almost all organs are involved. Body is forming antibodies against DNA. Anti-DNA antibodies are formed. So DNA is present in all the cells. Nucleus of all cells contain DNA. So that antibodies will target all the cells of the body. So multiple organs are involved. Heart is one of them. So I'm not teaching you SLE. I'm teaching you endocarditis in SLE. So in heart, there are 3 layers: endocardium, myocardium, pericardium. So only endocardium is involved. Myocardium and pericardium in SLE is not involved. There is no pancarditis. There is only endocarditis. It is not like rheumatic, it is there pancarditis. Waisa nahi hai. Only endocarditis is there. Correct or not? And endocarditis, maybe there are 2 endocardium, valvular and mural. So here only valvular is involved. Mural endocardium is not involved. So in valvular endocardium, here vegetations are formed, but vegetations here are different from that of rheumatic. So you have to mark or highlight the differences. Vegetation to wahan bhi bane hai, yahan bhi bane hai. There the reason was autoantibodies due to group A beta streptococcus antibodies. Here autoantibodies against DNA. So vegetations wahan bhi bane hain, vegetations yahan bhi bane hain, but vegetations are different. Vegetations are different, correct or not? So here also vegetations are formed. So can you see there are 3 layers in the heart? There are 3 layers in the heart. So innermost layer I have shown with the red color, middle layer black color myocardium, and outermost layer green color pericardium. So here only endocardium is involved. Myocardium, pericardium not involved. In the endocardium, only valvular endocardium is involved and vegetations are formed. I have shown the vegetations with yellow color, but you can appreciate the location is somewhat different as compared to rheumatic. We will study. So again, here vegetations are formed. It is seen in SLE. What is SLE? It is systemic lupus erythematosus disease. SLE. It is an autoimmune disease in which body is forming antibodies. Again, body's own DNA, and DNA is present in all cells. So it will target or hit all cells and multiple organs. It is a multi-systemic disease. Correct or not? It is a collagen disease. Correct or not? So that was the introduction. Here, vegetations are formed in the heart because valvular endocardium is involved. Vegetations are formed. We will describe the vegetations in 4 headings. First, we will describe the vegetations gross. Then we will describe the wall, which wall is involved. Then the location of the wall. What is the location of the wall? Upper surface, lower surface, that is upper is atrial surface, ventricular surface, or the junction. What is the location? And the last thing is deformity. Is there any deformity? Yes or no? Tell me. So we will describe vegetations always in these 4 headings. First, describe the gross. वहां की ग्रॉस से इसके ग्रॉस को कंपेयर करना. You have to compare. Here the vegetations are medium size, not small, as contrast to rheumatic fever. Yes or no? So vegetations are medium size. वहां भी multiple थे, यहाँ भी multiple है, but they are flat. They are not concave or convex. They are flat, verrucous. That's why it is known as verrucous. What is the name given? It is the atypical verrucous. The word verrucous means flat. Here vegetations are relatively flat. So you have to write the word flat / verrucous. They are granular and again they are sterile. It is not formed by bacteria. Bacteria वहां भी नहीं था, यहाँ भी नहीं है. उधर भी sterile था, इधर भी sterile है. So rheumatic also it was sterile. Here also in SLE it is sterile. Say yes or no. Say yes or no. Have you got it? So these are the gross findings. So it is flat. Yes. So compare this rheumatic vegetations with Libman-Sec vegetations. Compare it. Compare the size. Compare the size. In rheumatic it is small. In Libman-Sec it is medium size. Compare the size. Now compare the wall. There, what was the sequence in rheumatic? Mitral followed by aortic followed by tricuspid followed by pulmonary. Yes or no? Here, what is the sequence? Mitral and tricuspid. Only 2 walls are involved. Aortic and pulmonary not involved. So mitral and tricuspid, they are involved. So compare it. Compare and contrast. Make a table. Make a table of it. So it is mitral and tricuspid. What is the location? What was the location there? What was the location there? in rheumatic fever, the location was at the line of closure, at the junction, at the line of closure. Say yes or no. What is the location here? It is not at the junction here. It is at the upper surface, that is atrial surface. It is at the lower surface, that is ventricular surface. Now look here, look here. So upper surface, can you see? This is the upper surface. This is the upper surface. Upper surface of this wall is known as atrial surface because it is towards atria. Lower surface of this wall is known as ventricular surface because it is towards the ventricle. So atrial surface is involved, ventricular surface is involved. Listen, listen. And the vegetations are extending. Atrial surface पूरा involved है. Involved होके आसपास के atria पे भी जा रहा है. Look, please appreciate what I have drawn here. Can you see? I have drawn vegetations over the upper surface and I am extending the vegetations over the atria. So atria पे भी थोड़ा बहुत जा रहा है. And same with the ventricle, lower surface, ventricular surface, wall pe to hey, it is there on the wall, but it is extending on the ventricle also. So it is extending over below the ventricle also. And in the pockets also, pockets is the junctions here, at the junctions of the atria and the wall. So pockets also. So what is the location? At both surfaces of the wall, not at the junction. Upper surface, lower surface. Atrial surface, atrial is the upper surface. Ventricular is the lower surface. At both surfaces it is there. It is also there in the pockets. Pockets is at the junctions, corners, and also the adjoining ventricle and atrial. Adjoining upar bhi ja raha hai, niche bhi ja raha hai. Have you got it? If you got it, give me a thumbs up. If you have any doubt, write your specific doubt. Otherwise, give me a thumbs up. I want everyone to participate. So give me a thumbs up if you got it. Yes or no? So that is the location. So that now please see this diagram and this diagram. Compare it. I'm sorry. Compare it. The first one is a rheumatic disease, rheumatic fever. So can you see it is at the junction? It is at the junction. And can you see in the Libman sec? In the Libman sec, I have where I have shown the vegetation. The vegetations I have shown at the upper surface also, or flip flap karke at the lower surface also. So see the beauty of the diagram. The diagram is from the Robbins and see the beauty. So vegetations are shown at both surfaces in the last diagram. Can you see upper mein bhi aur flip flap karke lower pe bhi hai. So it is just by intention to show you vegetations are present at both surfaces. Yes or no? Give me a thumbs up. So yes, you have got it. So Sanjana is asking which wall is more involved. So I have told you mitral and tricuspid both are equally involved here. So aortic and pulmonary are not involved. So that is the thing. So that is the thing. What is the deformity? What was the deformity there? Fish mouth or buttonhole. Here there is no deformity. No deformity here. So no deformity. We are done with it. Their Ashkoff bodies were formed. Here hematoxylin bodies are formed. Hematoxylin bodies of Gross are formed. You have to learn the name only. Don't learn the composition of this. It is not important. But learn the name. वहाँ पे Ashkoff bodies थी. यहाँ पे hematoxylin bodies of Gross is formed. So it is formed. So we are done with the vegetations. We are done with this type of endocarditis. There is no myocarditis, no pericarditis. So only endocarditis is there. That is over. Endocarditis is sirf tha. It is done. Say yes or no. So should I proceed? So only endocarditis was there. So compare it. Compare the rheumatic endocarditis with Libman-Sec endocarditis. Out of the 4, we are done with 2. We will compare it first. Then we will start the third one. So here in rheumatic, the vegetations were small and warty. Here vegetations are medium size. Number 1. Number 2, their vegetations were firm and firm. Here vegetations are flat and verrucous. Here it is flat and verrucous. Take this word, Libman-Sec. Number 3, friable. What do you mean by friable? Friable yani toot jana, brittleness, brittle, friable yani toot. Vegetation, it is a nodule na, it will break and go away. So that is the friability. So friability दोनों में से किस में ज़्यादा है? Which is more friable? So friability की बात करें तो both are friable but less. Both are friable but less. So rheumatic is also friable. Libman-Sec is not very friable, but you can say it is a small amount of the friability is a main feature is NBT and infective. Main feature will be the rest of the friability. Here friability is not important. यहाँ पे vegetations टूट के आगे नहीं जाएंगे, but rest of the 2 endocarditis vegetations will break there and go ahead. So friability is not an important feature here. Location in rheumatic fever, it is line of closure, and here it is on the both surface and also in the pockets and also in the adjoining atria and ventricle. So also in the pockets and also in the adjoining atria and ventricle. That is the location. Vegetation sterile वहाँ भी थे, यहाँ भी sterile ही हैं, because bacteria is not formed. In both of them, vegetation is formed by autoantibodies. But autoantibodies are different. Their autoantibodies are against bacteria, group A beta streptococcus bacteria and rheumatic fever. Here autoantibodies are against DNA. Say yes or no. So it is seen in rheumatic fever. It is seen in SLE. So that is, we are done. So comparison is done. Yes or no? So I'm starting the third one, that is NBTE, non-bacterial thrombotic endocarditis. In non-rheumatic endocarditis, we are done with Libman-Sack, atypical verrucous endocarditis. Now I'm starting with NBTE, non-bacterial thrombotic endocarditis. So write its name, NBTE, non-bacterial thrombotic endocarditis, also known as catetic endocarditis, marentic endocarditis. So take this names. In marentic endocarditis, once there was an MCQ by this name. So you should know other names also. So here also endocardium of the heart is involved. That's why it is endocarditis now. Here also valvular endocardium is involved. So here also vegetations will be formed, but vegetations will be different. So why vegetations are formed here? What is the reason of formation of vegetation here in this disease? Here the vegetations are formed due to hypercoagulable state. You know hypercoagulable state, in our body blood vessels contain the blood, but blood when we have injury somewhere, blood comes out, oozes out. After some time there is the blood bleeding stops because coagulation is there. We have automatic coagulation there and bleeding stops. So whenever we have injury, coagulation takes place. It is a normal phenomenon. To stop the bleeding, it is necessary. It is necessary to show the coagulation. It is there. It is automatically there. But without injury, if someone is having coagulation without injury inside the blood, so small vegetations are formed. Small thrombus is formed, and that thrombus will form the vegetations. So here it is known as non-bacterial thrombotic endocarditis. So here vegetations are due to thrombosis. So here again sterile vegetations are formed. Bacteria is not there. Bacteria is not forming the vegetations. The vegetations are formed due to hypercoagulable state. Say yes or no. So hypercoagulable state is responsible for it. Hypercoagulable state means there is formation of thrombus without injury. Coagulation is there without injury inside the intact blood vessel, you can say. So it is hypercoagulable state. So again vegetations are formed, you can see. So vegetations we will describe in those 4 headings only. We will describe the gross, then walls, then location, then deformity. So what is the gross here? Again vegetations are small. पहले वाले में small थे, दूसरे में medium थे, तीसरे में वापस small हो गए. They can be single, they can be multiple. In rest of the two, they were always multiple. Here it can be single also, multiple also. They are brownish in color and they are friable than rest of the two. Rheumatic fever also, Libman-Sack also, they are more friable. They detach. They just detach from their site and go ahead in the blood. So they have tendency of detachability. That is friability. And again, they are sterile because bacteria to yahan bhi nahi hai. Bacteria चौथे वाले में आएगा. And the last one, bacterial or infective endocarditis, the vegetations will be non-sterile. Correct or not? Here also the vegetations are sterile. So that is the gross. So multiple vegetations are formed. You can see the vegetations by yellow color on walls. The vegetations are small, they are single, multiple, they are friable, and they are sterile. They are sterile. So compare. This is the first one, rheumatic heart disease. This is the second one, Libman-Sack. This is the third one, NBTE, non-bacterial thrombotic endocarditis. So this is the third one. Which wall is involved? Mitral followed by aortic, followed by tricuspid, and pulmonary is not involved. So sequence is same as that of rheumatic. Sequence is same as that of rheumatic. Mitral followed by aortic, followed by tricuspid. Pulmonary is not involved, not at all involved. So the sequence is same. Location is also same as that of rheumatic. That is along the line of closure. So you know what is the location. It is along the junction of the cusp or leaflets and at the line of junction. So location and walls both are same as that of rheumatic. Deformity, they form fibrous nodules. Deformity, there was fish mouth or buttonhole in rheumatic fever. Here it is fibrinous nodules. So we are done with the vegetations here. So we are done with the third one also, NBTE. Here vegetations are small like that of rheumatic, but in Libman-Sack it was medium. So we are done with the first 3, rheumatic, Libman-Sack, and NBTE. Correct or not? Here they are friable. The first 2 were not friable. This one is friable. The vegetations are detachable. The vegetations are along the line of closure like rheumatic fever only. Vegetations are along the line of closure and they are sterile. Sterile ही है ये तीनों. First 3 are sterile because not bacteria is involved. You know the mechanism why it is formed. It is seen in hypercoagulable state. Libman-Sack is seen in SLE and rheumatic fever is seen in rheumatic fever only. So that was the comparison. Coming on the last one, infective endocarditis, which is little bit longer. Like rheumatic one, it is longer and important one also. So those who are second prof MBBS student, theory question can come, big question, long question. 5-mark question can come on rheumatic fever, or it can come on infective endocarditis. Both are long questions. And small question, 2-mark or 3-mark, can come on Libman-Sec or NBT. These two are small questions. So you have to prepare your answer like the weightage of the question. So infective, important, it will be long. So I will start it. But before that, I would like to launch some MCQs based on NBT and Libman-Sec. Are you ready for the MCQs? Are you ready for the polls? Should I launch it? Give me a thumbs up if you're ready for the polls. Polls based on Libman-Sec endocarditis and polls based on non-bacterial thrombotic endocarditis. Rheumatic endocarditis polls we have done in the last lecture. Those who have missed the last lecture, don't dare to miss it. Watch the recording. You can't dare to miss it. And share it with your friends also, with your colleagues, with your batchmates, everyone who is an aspirant of any competitive medical exam, or who is a second prof MBBS student who is having pathology as their major subject. So they have to watch that lecture. If you have missed the live one, watch the recording. Correct or not? So I'm launching the poll. You people are ready, I guess. So this is the first poll in front of you. Please do it. Just read the question. You have only 15 seconds. Yes. You have only 15 seconds. Flat vegetations. One clue is flat here. In the pockets of the wall. Second clue is pocket. So 2 clues are given in the question. You have to take the clues from the question, na? Vegetations to hain. Vegetation to charon mein hote hain. All 4 diseases contain vegetation. But what is the specific thing given about the vegetation? It is flat and it is in the pocket. It is seen in what? So most of you are correct. The correct answer here is Libman-Sec. Yes. So Sushma, Samarth Nayak and Yashika Bhaki are first to answer. Great. I'm happy. You people have answered it correctly. Most of you are correct. But these 3 are the first one to answer. So the correct answer is Libman-Sec. So B is the correct answer. You can see in Libman-Sec, the vegetations are flat. They are verrucous and they are seen in the pockets. They are seen in the pockets of the wall. Along with both surfaces, upper and lower, they are also seen in pockets and adjoining atria and ventricle. Yes or no? So Libman-Sec is the correct answer here. So we will go with B. We will go with B. Any doubt? If you have any doubt, please write in the chat box. I will try to address it. So Saham is asking, hematoxylin is characteristic like Ashkoff bodies. No, Saham, it is not a characteristic feature. You have to just learn the name of the body if it is asked in MCQs. Otherwise, it is not pathogmatic feature here. So it may be seen in other diseases also. So that was the first question. This is the second question in front of you. Please read it. Please read it and attempt it. Please read it. Which type of endocarditis has vegetations on both surfaces of the walls? On upper surface also and lower surface also. Which type of endocarditis it is? So which type of endocarditis it is? Yes, most of you are correct. The correct answer is again B, Libman-Sec endocarditis. So Lakshmi, Mahabhav and Yashika. Again, first to answer. Great, I'm happy. So the correct answer here is B. So the clue was on the both surfaces. In rest of the fourth wala to abhi I have not taught you the fourth one. Infective, we will study. But in the first 2, it is along the line of closure. The vegetations are along the junction line of closure. In Libman-Sec, it is over both surfaces, not at the line of closure. So the correct answer here is Libman-Sec. Correct answer here is B. Correct answer here is B. So coming on the third question, this is the third question in front of you. Please read it. Vegetations in Libman-Sec endocarditis are vegetations. You have to describe the vegetations. Describe it. Read the conditions and describe it. Which one is correct? Yes. So whether they are large and fragile, whether they are small and warty along the line of closure, whether they are small or medium size on both surfaces, or whether they are small and bland. So you have to take it one by one. Again, it was a tricky question for me. It is simple, but yet it is tricky, I guess. So most of you are correct. You got the concept. The correct answer here is C. The correct answer here is C. And Lakshmi, KSR and Yashika are first to answer. Great. So why it is C? Why? We will exclude one by one. First option is large and fragile. Fragile होते हैं, ये तो सही है. Fragile होते हैं, इतने fragile, it is not very much fragile. The more fragile are the third one, that is NBT. So it is not very much fragile and it is not large, it is medium size. So first option is incorrect. Coming on the second option, it can be small, it can be medium or small, but not at the line of closure. Not at the line of closure. It is present over both surfaces. That's why second option is also incorrect. Fourth one, it is small, bland vegetations. They are bland. Agreed. They are bland, but they are not small. They are medium size. They are medium size. Again, the fourth option is correct. Now look at the third option. Look at the third option. They are small or medium. So basically they are medium, लेकिन small भी हो सकते हैं, चलो मान लिया. And they are present on both surfaces. So the third option is correct. So the correct answer here is C. So you have to see one by one. You should know what is correct. Okay, agreed. But an intelligent student should also know the other three, why they are incorrect. So that should be your extensive knowledge. Why other three are incorrect? Correct or not? So that is the thing. So correct answer here is C, and most of you are correct. This is the next question in front of you. Yes. This is the next question. Just a second. It is a tricky one, I guess. Yeah. No, it is a tricky question. Very tricky question. I have not taught you the fourth one. Now, if I have taught you fourth one also, infective endocarditis, bacterial endocarditis, then I have launched this question now. ये और difficult हो जाता. It may be more difficult, but it's okay. The fourth option is not there. Infective is not there in options. So you shouldn't be confused. So most of you are correct, not very much, but yeah, the correct answer here is A, Libman-Sachs. Libman-Sachs endocarditis. What is the question asked? Vegetations below AV walls. What are AV walls? Atrioventricular walls. There are 4 walls now. This is the heart. There are 4 walls in the heart. These are the 4 chambers in the heart. So this is the left side and this is the right side. Left side and right side. On the left side, and these are the blood vessels arising from the ventricle. So these are known as AV walls. Mitral wall and tricuspid wall, these are present between atria and ventricle. That's why these two are known as AV walls. AV walls means atrioventricular walls. They are present between atria and ventricle. And these two are known as semilunar walls. These two are known as semilunar walls. This is aortic on the left side and pulmonary on the right side. So these two are known as semilunar walls. So if I am saying semilunar walls, you should consider these two, aortic and pulmonary. If I am saying AV walls, you should consider mitral and tricuspid. Now read the question. What is the question? Vegetations below AV walls, below AV walls. So what are AV walls? AV walls are mitral and tricuspid. So vegetation seen just below them, below on the lower surface. So there is no endocarditis जिसमें vegetation सिर्फ lower surface में हो. But Libman-Sachs में it is present on upper also and lower also. So we can consider this question as partially correct. So vegetations only not below. It should be on the both surfaces. But upper भी है, lower भी है तो सही ना. Below भी होता तो है ना. So we will consider it as Libman-Sachs. So that was a trick in the question. Have you got it? What I want to say? Question was more correct if instead of below there should be both. If instead of below, question should contain both surfaces of AV wall. Question should be more correct. लेकिन जो भी question exam में आया, we cannot change the question. ना, we cannot raise our hand and say question is incorrect, change it. Whatever question comes in the exam, we have to attempt it. So this is the question asked in the previous exams. So instead of below, there should be both. Question will be more correct. I got it. But below भी है तो upper below दोनों में below भी होता तो है ना. So go with Libman-Sachs. So that was the trick in the question. Have you got it? Have you got it? So that was the thing. So correct answer here is A, according to me, not rest of the 3. So the other options are NBTE. In NBTE, it is along the line of closure, and in rheumatic, whether it is acute or chronic, in rheumatic always along the, in rest of the 3 option, it is along the line of closure. So it is not on the above surface, it is not on the lower surface, it is only at the line of closure. Libman-Sachs mein it is on both surface, both mein lower bhi aa jayega na. So below is the correct answer here. So that was a trick in the question. So we are done with it. So Samarth, SS and Mittapalli, Sanjana Mittapalli are first to answer. Great. So that was the correct option. So we are done. We are done with the rheumatic endocarditis. Pehle hi ho gaya last lecture mein. Today we are done with Libman-Sachs. We are done with NBTE, non-bacterial thrombotic endocarditis. Coming on the last endocarditis, infective endocarditis. Bacterial endocarditis or infective endocarditis. So bacterial endocarditis or infective endocarditis, one and the same thing. Very, very, very important. Make 5-star over it. Make 5-star important over it. So it will come for 5 marks in theory, in second prop. And for MCQ purpose, it is very important. I will launch the MCQs also. Don't worry. So I'm starting with it. Headings are a little bit more because it is extensive. So why it is happening? As the name indicate, bacterial endocarditis, it is caused by bacteria. So here bacteria will involve the endocardium of the heart. Heart has 3 layers. So endocardium is infected by the bacteria. And basically from the endocardium, valvular endocardium is involved. So bacteria will form the vegetations here. So here vegetation contain bacteria and vegetations are non-sterile here. as contrast to rest of the three. Vegetations were sterile in rest of the three endocarditis. Here vegetations will be non-sterile because it is caused by bacteria, and bacteria itself are present in the vegetations. So it is caused by bacteria. So infective endocarditis, as the name indicates, it is caused by microorganisms, especially bacteria. It is typically infected. The vegetations contain bacteria. Vegetation के structure के अंदर the bacteria is present, and it is friable. It is most friable out of the four. Out of the four, two are non-friable, two are friable. कौन से दो friable हैं? NBTE and infective bacterial endocarditis. Out of these two, bacterial is the most friable, most detachable. The vegetation will detach from its side from the wall, and it will move ahead with the blood. Correct, with the flow of the blood. So it is of two types. Bacterial endocarditis is of two types, Abe and Sabe. Abe means acute bacterial endocarditis, and Sabe means subacute bacterial endocarditis. So acute and subacute are basically two terms. What do you mean by it? Again, I would like to tell you a story here. Listen, two hearts in front of you. You can see there are two diagrams, four chambers, two auricles, two ventricles. You can see the heart. You can see the walls, mitral and tricuspid wall. What I want to say here, just suppose, imagine the first heart. The first condition here, the walls are healthy. Healthy means it is healthy. My heart walls are healthy. My heart walls do not have any disease. So mitral and tricuspid walls are healthy. And in the second situation, the walls are diseased. The walls are diseased. There is some disease in the wall. Mitral and tricuspid wall, there is some disease. So in the first situation, when the heart walls are healthy, if a bacteria is coming on the heart wall, just suppose a bacteria, I'm drawing the bacteria with green color. If a bacteria is coming here and wall is healthy, so if bacteria want to involve the wall, bacteria should be highly virulent. No, bacteria should be powerful, virulent, because heart wall is very healthy. To damage it, to involve it, bacteria should be very much powerful. Powerful means virulent. And in the second situation, heart wall is already diseased. It is already flabby. It is damaged already. So here less virulent bacteria will also suffice. If bacteria is less powerful, then also bacteria can cause damage there in the second case. In the first case, highly virulent bacteria is like Staph aureus. Staph aureus is a highly virulent bacteria. In the second situation, Streptococcus viridans is a less virulent bacteria. So here bacteria is Streptococcus virulens. And in the first case, it is Staph aureus. It is highly virulent. And in the first case, because bacteria is highly virulent, it will take less time to damage the wall. So less than 6 weeks are required. In the second case, because bacteria is less virulent, bacteria will take more time to damage. So it is more than 6 weeks. So first case is known as Abe, acute bacterial endocarditis, and second case is known as Sabe. Now you tell me the difference between Abe and Sabe. In Abe, acute bacterial endocarditis, less than 6 weeks is required. Once the bacteria enters in the body, in less than 6 weeks, vegetations are formed. Bacteria should be highly virulent. Example, Staph aureus, and heart walls are healthy. Just reverse, in the Sabe, subacute bacterial endocarditis, once the bacteria enters in the body, just suppose in my body, it will take more than 6 weeks to cause vegetations. More than 6 weeks are required to cause the vegetations. Bacteria is less virulent. That is Streptococcus viridans. Examples is Streptococcus viridans. And here the heart walls are already damaged, already diseased. Say yes or no. Give me a thumbs up if you got it. So there are two types of endocarditis, Abe, Sabe, acute, subacute bacterial endocarditis. If we talk about acute one, acute bacterial endocarditis, it is caused by highly virulent bacteria like Staph aureus, and it is caused in normal heart walls, healthy heart walls. And here less than 6 weeks is required. Less than 6 weeks is required. Coming on Sabe, subacute bacterial endocarditis, here less virulent bacteria is required, like Streptococcus viridans. Less virulent bacteria is required. It is caused in previously diseased wall, not healthy wall. यहाँ पे पहले से ही person को disease है, तो उसका wall तो पहले से ही weak है ना, तो less virulent भी करवा लेगा disease. That is the concept here. And here more than 6 weeks is required because bacteria is less virulent, so more time is required here. So that is the difference between Abe and Sabe. Learn it like a concept. You will never forget. If you mug it now without understanding, ulta pulta hone ka chance hai. You will have a chance to mix up in the exam. But if you take the concept now, you will never mix up. You will never forget. No need to learn. Just understand now. If I am a healthy person, my heart is healthy, my heart walls are healthy. So my heart walls are healthy. They are not diseased. So more virulent bacteria is required to damage my heart walls. What is the example of more virulent bacteria? Example is Staph aureus. And bacteria is very powerful. It will take less than 6 weeks to damage the walls and to cause the vegetations over it. So it is known as Abe. Just reverse the situation. If I'm a person, I'm having diseased heart walls, I'm having mitral regurgitation, mitral stenosis, aortic stenosis, any disease in the heart wall, already I'm in hemodynamic compromised state. Just for say, I'm not, but I'm, for example, I am. So if any less virulent bacteria enters in my body, so that less virulent bacteria will also be able to damage the heart walls, because heart walls are already flabby, they are damaged. So the example of less virulent bacteria is Streptococcus viridans, and bacteria will require more than 6 weeks time, because bacteria is less powerful. It will require more time to damage the heart walls. It is known as SABE. So these are the two conditions. Have you got it? So just read the differences. Many MCQs comes on this point. So ABE, SABE, acute, subacute, less than 6 weeks, more than 6 weeks. Highly virulent bacteria like Staph aureus, less virulent bacteria like Streptococcus viridans. Please mind it. The first situation is Staphylococcus aureus. The second is Streptococcus viridans. Don't confuse. Staph, strep. Correct or not? So here the heart walls are normal. Here the heart walls are previously diseased or damaged. So that is the condition. That is the condition. So we are done it with it. What is the etiology? Etiology is bacteria. In ABE, it is Staph aureus. In SABE, it is Strep viridans. So we are done with it. Yeah, some important points. If I ask you most common bacteria for ABE, your answer will be Staph aureus. Everyone knows. What is the most common bacteria for SABE? Your answer will be Strep viridans. Everyone knows. But if I don't ask ABE and SABE, if I ask what is the most common bacteria and bacterial endocarditis overall, what will be your answer? ABE के लिए most common पता है, SABE के लिए most common पता है. Overall क्या है? Overall, yes, Jaydev, it is Staph. So overall also it is Staph. It is Staph. ABE के लिए Staph, SABE के लिए Strep. Overall it is Staph. What is the most common bacteria causing bacterial endocarditis in intravenous drug users? In intravenous drug users, you know, there are drug users, intravenous drug users. So again, in intravenous drug users, the most common bacteria is Staph aureus, which cause vegetations in them. Bacterial endocarditis is very common in the persons who are IV drug users, who give drugs again and again in their veins, IV veins. So bacterial, and because of they do not use the sterile conditions while injecting the drugs, so bacterial endocarditis is very common in them. And most common bacteria which cause bacterial endocarditis in drug abusers is Staph aureus. So again, important MCQs. Now just suppose my heart walls are damaged. Just suppose if any person is there and the walls are damaged, the heart walls are damaged. So what will be done? We will give a prosthetic heart wall to them. We will replace the normal wall with an artificial wall. That artificial wall is known as prosthetic wall. To save the person, we implant a prosthetic wall in them. Prosthetic wall surgeries are common. So if any of the 4 walls is damaged, prosthetic wall replacement is there. But when prosthetic wall is there, it is not natural wall, it is prosthetic wall, then endocarditis is very common in them. Endocarditis is very common in them after surgery. So if my normal wall is replaced with some artificial wall, it is known as prosthetic wall. And prosthetic wall endocarditis is very common after surgery. If prosthetic wall is involved by bacteria after surgery within a year, within less than 12 months, within a year, it is known as early endocarditis. And if it is involved after 12 months, after a year, just suppose my surgery is done today, within a year, if I am having endocarditis in my artificial wall, it is known as early prosthetic endocarditis. If after 1 year, after the surgery, after 1 year, I am having endocarditis in my artificial wall, in my prosthetic wall, it is known as late endocarditis. So which bacteria causes early prosthetic wall endocarditis and which bacteria causes late prosthetic wall endocarditis? 2 different MCQs. Have you got my point? So early prosthetic wall endocarditis, that is within 12 months of the surgery. So it is caused by Staph aureus, and late one after 12 months of the surgery, the late one is caused by Strep viridans. Again, 2 important MCQs. Have you got it? Give me a thumbs up if you got it. Yeah, come on. So that was the thing. Again, 2 important MCQs. These are all important points are for your MCQs. Correct or not? So take it judiciously. Yes. So those who are doing any dental procedure, especially root canal procedure, most of you have done. I have done one of my tooth, root canal procedure. So root canal procedure is done. So in root canal, if the dentist is not using the instruments very sterile, so infection will go in the blood vessels and infection can go in the heart. So in dental procedure, infection to the heart is very common if dentist instruments are not sterile. He is not using sterile instruments. Then most common bacteria causing endocarditis in dental procedures, Streptococcus mutans. streptococcus mutans in root canal procedures or in tooth extractions procedures. So because bleeding is very common in tooth extraction, correct or not? So streptococcus, all these are important MCQs. Take it there. There are some predisposing conditions which increases the risk of bacterial endocarditis. If I am having any of these conditions, I am at more risk than a normal person of having bacterial endocarditis. So high risk condition are VSD, ventricular septal defect. You know what is VSD? You know now what is VSD? So there are two ventricles. Now this is left ventricle, this is right ventricle. So there is a septum between the two ventricles. If this septum contains a hole, it is known as ventricular septal defect. And blood flows from left to right side because pressure of blood is always more on the left side, less on the right side, and blood flows from high to low pressure. So through this hole, blood will go from left to right side. This is known as VSD. And ASD mein hole is there in the atrial ventricular atrial septum, interventricular septum. So VSD, mitral regurgitation, prosthetic valves, TOF, PDA, aortic stenosis, mitral regurgitations. These are high risk lesions. There are some moderate, low risk. Don't learn the moderate, learn high and low. But you will moderate. So for MCQ purpose, you have to learn. If any person is having any of these diseases, he is having that risk of having bacterial endocarditis as compared to normal population. So what is the lowest risk? If a person is having ASD, he is at the lowest risk. If a person is having VSD, he is having at the highest risk of having bacterial endocarditis. Take these for MCQs. Correct. So highest risk is VSD. Lowest risk is ASD. So learn this. If you can learn complete table, it is good. If you can't learn complete table, learn these two for MCQs. Highest risk is में VSD में, and lowest risk is में ASD में. So Jaydev is asking what is PDA? It is pulmonary ductal this thing. I will come on PDA also. So just a second. Yeah. So why in these all? You should ask now, ma'am, why in these all, why the person is at high risk? Why the person is at high risk? So in any of these, blood flow will be abnormal now. So one of the four wall will be under hemodynamically stress, and bacteria can easily injure that hemodynamically stressed wall. Just for say, I have told you now, if there is VSD, blood will flow from left to right side. So this is the left side, this is the right side, this is the hole. So all the blood will move from left to right, and this wall will be at highest stress. This wall, that is pulmonary wall, will be at highest stress. So one of the wall will be at highest stress in all of these lesions, and bacteria can easily injure it, and that will cause bacterial endocarditis. So we are done with it. Now describe the vegetations. Vegetations are formed. Describe the vegetations. Their gross, their wall, their location, their deformity. Again, same four headings. So describe the gross. The vegetations are large here. So small किसमें होते हैं, medium किसमें होते हैं, large किसमें होते हैं? You answer it. Now you will answer it. What are small? What are medium? What are large? So small are present in rheumatic endocarditis and NBTE. Yes, medium are present in Libman-Sec, and large are present in bacterial endocarditis. Never forget. They are also single or multiple. They are friable. Most friable. इन चारों में से सबसे friable are bacterial. Why friable पे मैं इतना stress क्यों डाल रही हूँ? Why I am stressing the word friable? Because if they are friable, vegetation will detach. Vegetation will detach from its place, and they will move along the blood flow, and they will obstruct other organs' blood flow. They will obstruct, they will form the thrombus, and they will go in other organs, and they will obstruct the blood flow of other organs. They will cause infarct in the body. So these are more dangerous. Friable are more dangerous. Yes or no? So friability is an important feature of vegetation. So here the vegetations are friable. They are bulkier. Why they are friable? क्योंकि बड़े-बड़े हैं ना तो टूट जाते हैं. They are bulkier. They are larger. That's why they detach from its place and move ahead from the blood flow, along with the blood flow. So that is the thing. So yeah, I want to tell you something here. So I have told you there are four walls. There are four walls. So this is mitral wall, this is tricuspid wall, this is aortic wall, and this is pulmonary wall. Mitral and tricuspid are known as AV walls. Why I am telling you, I have a reason. AV walls, and pulmonary and aortic are known as semilunar walls. Semilunar walls. Okay, listen. What I want to say, all walls have two surfaces. See AV walls first. See AV walls, mitral and tricuspid. So see any of the mitral or tricuspid. See mitral wall. This is a mitral wall. I am drawing it. And this is a tricuspid wall. So mitral wall upper surface contains atria and lower surface contain ventricle. So AV walls upper surface have atria and lower surface have ventricle. Yes, okay. What about semilunar walls? Look at the aortic wall and pulmonary wall. What is the upper surface? What is the lower surface? Aortic and pulmonary wall, that is semilunar wall mein upper surface is ventricle. Upper surface is ventricle, agreed or not? And lower surface is a artery. Lower surface is a artery. In aortic wall, it is aorta. In pulmonary wall, it is pulmonary artery. Lower surface is artery. Give me a thumbs up if you got it. Upper and lower surface of all four walls. So AV walls, upper surface atria, lower surface ventricle. It is visible now, no need to learn. And in semilunar walls, upper surface is ventricle and lower surface is the artery. Give me a thumbs up if you got it, correct or not. So what is the location of vegetations here? These are the four walls I have told you, two surfaces I have told you. So see the location of vegetations. I have drawn the vegetation on all four walls to show the location to you people. To show it is not present on both surfaces like Liebman sac. It is not present at the line of junction like rheumatic and NBT. It is present only on one surface. Which surface? Upper surface. Not on lower surface, only on upper surface. So if I say about AV walls, look at mitral wall and tricuspid wall, the upper surface is atrial. So it is present on atrial surface of AV walls. And about semilunar walls, upper surface is ventricular, lower surface is atrial. So AV walls के atrial surface पे होते हैं and semilunar walls के ventricular surface पे होते हैं. Give me a thumbs up if you got it. That was a difficult concept, but I tried my best. So AV surface के atrial surface पे vegetations होते हैं and semilunar walls के ventricular surface पे vegetations होते हैं. So vegetations are present on atrial surface of AV wall and ventricular surface of semilunar wall. Both of these are upper surfaces of these walls. So in short, vegetations are present on upper surface of all walls. Done? Got it? So that was the concept. So that was a simplified diagram. I can draw it for you. So what is the location? You tell me. What is the location? You tell me. So this is the location. Let me write it. Location, I have not written it here. Just a second. Yeah. So this is the location. Atrial surface of AV wall and ventricular surface of semilunar wall. In short, upper surface of all wall. Upper surface of all. In short, upper surface of all walls. So upper surface of atrial AV walls is atrial surface and upper surface of semilunar walls is ventricular surface. So no need to learn. Upper surface of all wall, not lower, only upper. In contrast to Liebman sac, which was present on both surface, upper as well as lower. Here it is present only on upper. So that is the location. Which wall is involved? Name the wall, name the sequence. Sequence is same. Sequence to हमेशा same ही रहेगा. So it is mitral followed by aortic. Mitral followed by aortic. Rest two walls are not involved. MA. Mitral followed by aortic. So that is the sequence. Mitral followed by aortic. So most common wall involved in all endocarditis is mitral only. So mitral wall. But in IV drug users, it is tricuspid. Tell me the reason. Why? Why in IV drug users, most common wall involved is not a mitral, it is tricuspid. Why? Can someone tell me the reason? Yes, Udit, because? So chocolate, Udit, Khushbu, because IV drug users used to give drug in the vein and all veins drain in superior inferior vena cava via superior inferior vena cava in the right side of the heart, and tricuspid wall is a wall on the right side, mitral wall is a wall on the left side. So their left side walls is not involved, right side walls is involved. So if a person is IV drug user, he will give the drug in the vein, not in the artery. The drug is given in the vein. Vein mein dega na. So all veins will drain where? All veins will drain on the right side of the heart via superior vena cava and inferior vena cava. So it will come on the right side. So drug ke saath saath agar bacteria bhi inject ho gaya, if the condition is not sterile, along with the drug, the person is injecting bacteria into the vein. So bacteria will also go along with the drug in the right side of the heart, and the first wall which comes in contact with the bacteria is tricuspid wall. So that's why tricuspid wall is more involved in IV drug users. Tricuspid endocarditis is common, correct or not? And in prosthetic wall, endocarditis is more common in aortic. So overall, there are 3 MCQs. Overall, bacterial endocarditis is most common in mitral wall. In IV drug users, bacterial endocarditis is more common in tricuspid wall. In prosthetic wall surgeries, endocarditis is more common in aortic wall. So 3 different walls are there. So in this diagram, you can write mitral wall overall endocarditis. Tricuspid wall, IV drug users endocarditis, and aortic wall prosthetic prosthetic surgery, endocarditis. So in this diagram, you can write all three. Yes or no? Give me a thumbs up if you got it. So that is the thing. That is the thing. Now compare the all four. This is infective endocarditis. You can see I have drawn vegetations only on upper surface, not on lower. Compare this with this. Compare the infective endocarditis with Libman-Sack endocarditis. In the last diagram, in Libman-Sack, you can see I have shown vegetation on both surface. Flip-flap करके दोनों surface पे दिख रहा है. But in infective, it is seen only on upper surface. And which is the largest one? In चारों में से सबसे बड़ा कौन है? Infective is the largest. Can you see इतना बड़ा single vegetation is there? It is not multiple. It is single बड़ा सा vegetation है. So largest one कौन सा है? Infective. So this is a beautiful diagram from Robbins showing all the condition. Which is smallest? Which is medium? Which is largest? Correct or not? And which is along the line of closure? Which is present on both surface? Which is present only on upper surface? All of them are important MCQs. Yes or no? So that is a beautiful diagram given in the Robbins, Hirschman. So you can see the vegetations here. These are the vegetation, small nodules. And deformity, yes, deformity is there. So what deformity? If bacterial vegetations are formed over these walls, so walls will get ulcerated or perforated, and there will be abscess. There will be abscess in the wall. You know what is abscess? Pus will be filled. Just a second. So can you see vegetations are formed in all these four walls? So vegetations, when they will form abscess there. Pus will be filled in the walls because bacteria is present in the vegetations. Vegetations are non-sterile, and after abscess, there will be perforation or ulceration. So wherever bacteria is present, ulcer is formed. So only endocarditis in which ulceration, perforation, and abscess formation is there, it is bacterial endocarditis. In rest of them, ulceration, perforation, that is not the thing. Correct or not? So that is the thing. Abscess is formed here. So most destructive vegetations are seen in bacterial endocarditis. It is most destructive. Vegetation तो चारों में बनेंगे, लेकिन सबसे destructive इसमें है because there is ulceration, there is perforation, there is abscess. Patient will have high grade fever because there is pus formation. Yes or no? So that is the thing. Here microscopy is also important. The vegetation's microscopy is important. So if I cut a vegetation and make a slide of it, I can see it like this. Can you see? This is a wall. This is a heart wall. So this is atrial surface, this is ventricular surface. So at the junction of atria and ventricle, there is AV wall. So this is the wall. This is the wall. And on the wall, you can see a vegetation, purple color vegetation. This vegetation has 3 zones. Zoom it out and see the 3 zones. I have drawn a red colored marking. Can you see a red colored marking there? So the outermost zone is red color zone. That red color zone is known as cap. That red color zone is known as cap. It is made up of fibrin and platelets. The outermost zone, red colored zone, is cap made up of fibrin and platelets. Middle zone is blue zone. Can you see blue zone? These are bacteria, the blue colored bacterial colonies. So middle zone is basophilic zone. Basophilic means blue zone, and it contains bacteria. It contains bacteria. And last zone, the yellow colored zones you can see here, the yellow colored zone. So red, blue, yellow. The last zone is deeper zone, and it is inflammatory infiltrate. So you can see the neutrophils, inflammatory infiltrate inside it. So tell me the 3 zones of the vegetation. Tell me the 3 zones. The red color is the cap, fibrin, made up of fibrin. The second is basophilic, made up of bacteria, bacterial colonies, basophilic zone. And the last zone is deep zone, made up of inflammatory infiltrate. Made up of inflammatory infiltrate. These are the 3 zones. So we are done. We are done. Just compare it. Then I will tell you the complications of infective endocarditis. We are done with infective endocarditis. The last one, infective endocarditis. Now compare it with the rest of the 3. So in rheumatic, the vegetations were small. In Libman-Sack, in NBT, the vegetations were small. In Libman-Sack, it is medium, but in infective, it is large. Most friable are this. Most friable. Rest 3 are not very much friable, but this one is friable. What is the location? In rheumatic, it is along the line of closure. In Libman-Sack, along the line of closure. In NBT, along the line of closure. In Libman-Sack, over the both surface. In infective endocarditis, only on upper surface. Not on both, only on upper surface. Correct or not? Vegetations were sterile in first 3, but here vegetations are non-sterile. They contain bacteria. They are non-sterile. Say yes or no. So have you got it? So I will tell you complications also of bacterial endocarditis. I will tell you complications also because complications are important here. So complications are of 2 types, cardiac and extracardiac. So cardiac complication, abscess is formed. In the heart, abscess is formed. Extracardiac complications. Now listen, I have told you these vegetations are detachable. They are friable. They are detachable. They will detach. So where they will go? After detaching, where they will go? My question, listen my question. They will form the ampulla, yes, Jaydev, but where they will go? If, yes, of course, organs, which organs? So if they are on the left side, they will move in the aorta. This is aorta. They will move in the aorta and they will move in all organs of the body, liver, spleen, kidney. And if they are on the right side, they will move in pulmonary artery and they will go to the lungs. So right side vegetations will form abscess. Bacteria will reach in the lung, will form abscess in the lung, and left side will form abscess in multiple organs. So abscess is, apart from heart, abscess will formed in multiple organs. So where if the bacteria, if the vegetations are from left side, they will form abscess in multiple organs via aorta. They will detach, they will move in the aorta, and they will form abscess in all organs of the body. And if they are present on the right side, they will move through pulmonary artery and they will form abscess in lungs. Say yes or no. So that is the thing. So can you see, this is an abscess, pus-filled abscess. I will show you. So this is a pus-filled abscess here. So perforation is there because of pus-filled abscess in the walls of the heart, in the vegetations. So extracardiac vegetations I have told you. So if it is on the left side, multiple organs abscess. If it is on the right side, pulmonary abscess. So that was the concept. That was the concept I have told you already. I have told. Yeah, one more thing. In the fingers, multiple nodules are formed because these abscesses will detach from the heart. They will move through the aorta. From aorta, they will come to the digits and they will obstruct the blood vessels of the digit, and nodules are formed in the digits, in the fingers, in the thumb, in the hands. So nodules are formed. So in Abe, the nodules formed is known as Janvey spot. And in Sabe, the nodules formed is Osler nodules. So you take these words for your MCQ. Janvey spot in Abe, Osler nodule in Sabe. Can you see? These are Janvey's nodules. These are seen in Abe. And these are Osler nodules. These are seen in Sabe. Osler nodules are at the tip. Can you see? This one is at the tip. And Janvey's nodules are at the palm. Janvey's nodules are at the palm. So Janvey's nodules, they are present on the pulp of the finger, on the palm. And Sabe, Osler nodules are present at the tip. So one is present at the pulp, one is present at the tip. One is Osler, one is Janvey. One is in Abe, one is in Sabe. And this one is painful. This one is painful. Pain is present. And this one is painless. Janvey is painless. Pain is absent. So which is painful, which is painless, you have to learn it. So this is painful and this is painless. So one is painful. So make a table of it. Osler, Janvey, Sabe, Abe. This is present at the tip. This is present at the pulp. This is painful. This is painless. So just make a diagram of it. Just make a table of it. This is important for MCQs. So that is the thing. So you can see again Osler and Janvey. This is Janvey. This is seen in Abe. This is painless. Painless. And this is present at the pulp. This is Osler. This is present in Sabe. This is painful. Pain is present. Just make it now, like me. And this is present at the tip. Make the diagram by your own. I know it is drawn here, but once you will draw by your own, you will never forget. So make a hand, make one nodule there, make one nodule there, draw a diagram, draw the differences, write the differences in diagram only. You will never forget. So Osler and Janvey. You can make mnemonic also if you are getting confused. So we are done with it. Last thing here, like in rheumatic fever, there were Jones criteria, 5 major, 5 minor, 3 supportive, yes or no. There were Jones criteria. Like that only, in infective or bacterial endocarditis, there is Duke's criteria. There were modified Jones criteria, here modified Duke criteria. Duke is the person, the scientist you can say, who has given the criteria for diagnosing bacterial or infective endocarditis. Say yes or no. So here there is Duke's criteria, not Jones criteria, modified Duke's criteria. There are 3 major, 3 major. I will read it. There are many minor, 1, 2, 3, 4, 5, 6. I think 6 minor and 2 supportive criteria. So 3 major, 6 minor and 2 supportive. So only major are important. I won't read minor and supportive. Major are important. So if a person is coming to me with some symptoms and I am suspecting bacterial or infective endocarditis in the person, then I will do a blood culture of the person. Blood culture should show either Staph aureus infection or Streptococcus viridis infection. So दोनों में से एक तो होना चाहिए. If it is Abe, it is Staph aureus. If it is Sabe, it is Streptococcus viridis. So blood culture should be positive for the infective organism. For the infective organism, number one thing, that is blood culture. Number two, I should do a echo. And in echo, there should be abscess in the heart. There should be valvular deformity. There should be implant-related prosthetic wall deformity. There should be some deformity in the echo, which is indicating there is some lesion in the heart. There is some organic lesion in the heart. And number two, there is new valvular regurgitation. On auscultation, if I am ausculting with a stethoscope, the person should show a regurgitation. Because if any of the wall is involved, regurgitation should be there. There should be a new onset regurgitation in the person. Give me a thumbs up if you got it. These are three major modified Duke's criteria for diagnosing infective endocarditis. What are they? Number one, blood culture positive for the organism. Number two, echo should show the lesion. Number three, new onset regurgitation on ausculting by stethoscope. These are the three criteria. Minor, you can read it by yourself. There is fever because bacteria hai body mein, to fever to aayega na. So number one, fever. Number two, predisposing heart condition, ASD, VSD, कुछ ना कुछ होना चाहिए, PDA or IV drug user. The person should be IV drug user. There are some lesions like Janeway nodules, Osler nodules. ये सब में से कुछ ना कुछ मिलना चाहिए आपको. And echocardiogram. Okay, so you can read it. Minor are not very important, but you should read it. You should know for MCQ purpose at least. And two supportive criteria, same as that of rheumatic fever. So these are the things. So we can do finally a comparative study of all these. I'm not reading this table once again. You can draw this table by your own. So we are done with all types of endocarditis. The 4 types of endocarditis: rheumatic endocarditis, non-bacterial thrombotic endocarditis, NBTE, Libman-Sec endocarditis, and last is infective or bacterial endocarditis. So all 4 types of endocarditis is done by me. So vegetations are formed in all of them, but the difference in vegetations is given in front of you. So size is different, location is different, wall is different, deformity is different. Yes or no? Yes or no? So ready for the polls? Yes, Jaydev, I'm launching the polls. Done? Any doubt? Give me a thumbs up if you're ready for the polls. So I would like to launch the polls based on bacterial endocarditis. Yes? Any doubt you can ask. I'm open to address it. Till now, any kind of endocarditis. We are done with the topic of endocarditis. I will start a fresh topic now after the polls. Done? Everyone satisfied? Okay. So this is the first question in front of you. Do it fast. There are 5 options, I guess. There are 5 options. Okay. So yeah, bacterial endocarditis most commonly caused by. I have not asked specifically for Sabe or Abe. Overall, I have asked. Overall, I have asked. I have not written acute or subacute. So it is overall. If it is not written anything, it is asked overall. So yes, most of you are correct. The correct answer is Staph aureus. The correct answer is Staph aureus. So Parag Goyal, Jaydev and Nandini Jain are first to answer. Great, good. So the correct answer here is C. Everyone is satisfied, na? Okay. So this is the next question in front of you. Please read it. Do it fast. 4 options are there in front of you. You have 15 seconds. The risk of developing an infective endocarditis is least in. I have asked least, not the most. Least. So I am asking about the predisposing factors. I have told you in predisposing factor which is having the most risk and which is having the least risk. If you can learn the complete table, it is good. If you can't learn the complete table, you should know the most and least risk. Most and least risk factor or predisposing factor. So least common, it is ASD. Least common, it is ASD. Most of you are correct. The correct answer here is D. So again, Parag Goyal, Jaydev and KS are first to answer. Good, great. So large ASD is the correct answer, D. If instead of least, question contains most, what will be your answer? Write in chat box. I'm not launching the poll. Write in the chat box. If instead of least, the question contains most, then what will be your answer? Yes, yes, you all are correct. You all are correct. Everyone is correct. The correct answer will be A in that case. That is VSD. That is VSD. So VSD is the most common predisposing factor and ASD is the least common predisposing factor for bacterial or infective endocarditis. So correct answer here in this question is D. Okay, done. So this is the next question. Yeah, VSD is the most common, ASD is the least common. You can see most common में 2 ही हैं, VSD and MR. These are more important. This is the next question in front of you. Just a second. Here the answer was D. Yeah, this is the next question in front of you. Okay, let me share the board first. Non-sterile vegetations are seen in. Very easy. I want everyone to be correct. जो इसमें incorrect है ना, I will slap that person. I'm going to slap yourself from my side. Those who are incorrect in this question. Non-sterile vegetations are seen in. I have told you 4 types of endocarditis. Now, the first 3 were sterile. The last one was due to bacteria. That's why it is non-sterile. So, non-sterile endocarditis is seen in. Infective endocarditis, the name itself indicated. The rest 3, rheumatic fever, NBT, and Libman-Sack, are sterile endocarditis because the vegetations are formed. The rest of the 3 do not contain bacteria. But in the last one, I have told you the diagram also, the blue colored basophilic colonies were bacteria. So, vegetations contain bacteria. That's why they are non-sterile. So the correct answer here is B. So Lakshmi, Yashika, and Sushma are first to answer. Okay, good girls. Great. So correct answer here is B. Correct. So this is the, I've shown you. So it is sterile, sterile, sterile. The last one is non-sterile. So it is infective endocarditis, which is non-sterile. Correct. So that is the thing. This is the next question in front of you. This is the next question in front. In which of the following vegetations are friable and easily detachable? So सबसे ज़्यादा friable किसमें होते हैं? जिसमें easily detach होके they forms nodules, Genovese nodules, Osler nodules, other abscess in the body. In which of the following vegetations are most friable? In which of the following? Yes. So the correct answer here is, most of you are correct. The correct answer here is D. It is infective endocarditis. So Yashika, Manush Modi, and Sanjana are first to answer. Great. So correct answer here is D, infective endocarditis. So it is the most friable, most friable. The rest 3 are not very much friable. They are friable, but not very much. The last one are most friable because the size is bulky. They are large. They are large. The rest 3 are small or medium. That's why they are not friable. The last one are bulky and large. That's why they are friable. So correct answer here is D. So this is the next question in front of you. Yes. Firm warty vegetations are seen along the line of opposition. Line of opposition means line of junction, line of closure. Line of closure पे कौन से वाले होते हैं? 2 होते हैं. उनमें से firm and warty कौन से होते हैं? So I have given a clue also. The question is tricky and most of you are incorrect. Most of you are incorrect. So correct answer here is C. The correct answer here is rheumatic heart disease. This is the correct answer. Now, line of opposition means line of separation, line of junction, line of closure पे कौन-कौन से होते हैं? Line of closure पे 2 होते हैं. एक rheumatic heart disease और दूसरा NBT. Both of them are present along the line of closure. But among these 2, firm and warty vegetations are rheumatic heart disease. So correct answer here is C. Only 40% people are correct. Rest all are incorrect. Why? I don't know. So correct answer here is C. So you can see the first one, the vegetations are firm. The rest 3 vegetations are not firm. So firm, warty along the line of closure. The answer is rheumatic heart disease or rheumatic fever. Say yes or no. So have you got it? Have you got it? Should I start the new topic? So we are done with endocarditis there. We are done with endocarditis. So in CVS, I have taught you cardiac adaptations. I have taught you heart failure, right heart failure, left heart failure, forward heart failure, backward heart failure. Then I have taught you MI, myocardial infarction, that is coronary artery disease, ischemic heart disease, angina. Then we are done with endocarditis, all 4 types of endocarditis, rheumatic heart disease, that was one of the endocarditis, bacterial endocarditis. So we are done with it. Now I'm starting a topic from blood vessel. Are you people interested to continue or should I leave here only? Should I start new topic? If I start, then I will finish. It will take half an hour, more half an hour. Are you people there? Give me a thumbs up if you want me to continue. Or should we continue in the next? Okay, okay, done. So most of you want me to continue, so I'm starting it. So I'm starting with blood vessel. I would like to tell you the structure of an artery. After that, I will start with the first topic, that is hypertensive arteriosclerosis. Very, very important. So the structure of the artery, we all know blood vessels, the arteries, veins and capillaries, they have 3 layers, intima, media and externa. So the detailed structure is shown here. Intima have 2 layers. Intima is made up of intima, media and externa. So just suppose this is a blood vessel. This is the lumen of the blood vessel. The innermost layer is intima. Then there is media. Then there is externa. So intima is having 2 layers. The innermost cells you can see, these are endocardial cells. So innermost is endothelium, not endocardium, sorry. Endothelium. The innermost layer is endothelium. I am marking with green. So endothelium are lined by endothelial cells. And just behind the endothelium, there is subendothelium made up of collagen. So made up of collagen, this is subendothelium. So first there is endothelium, then there is subendothelium. Subendothelium is made up of collagen. Please mind it. In atherosclerosis, it is important. It is important when I will explain you atherosclerosis. Then the middle layer is media. Middle layer is media. Intima के बाद media. Media contains smooth muscle cells. The pink colored cells you can see. You can see the pink or purple colored cells. These are all smooth muscle cells. This is tunica media. Tunica media. It contains smooth muscle cells. Smooth muscle cells are present only in media, neither in intima nor in externa. They are present only in media. And in atherosclerosis, these smooth muscle cell will migrate from media to intima. ये माइग्रेट करके आएंगे मीडिया से इंटिमा के अंदर, तो एथेरोस्क्लेरोसिस होगा. I will explain you this in atherosclerosis. Just learn the basics now first. Smooth muscle cells are present only in media, not in intima, not in externa. And the outermost layer is externa. You can see here, it is externa, adventia or externa. So there are three layers, intima, media and externa. Intima, there are two layers. Endothelium, which is lined by endothelial cells, and subendothelium, which contains collagen fibers. This is intima. Contains two layers. Then there is media. Media contains smooth muscle cells, the purple color cells. So this is media. And then there is externa. So externa or adventia. It also contains collagen fibers. So these are the three layers, intima, media and externa. Media contains smooth muscle cells. Give me a thumbs up if you got it. Done? So, okay. So, yeah, these are some important MCQs you can take. Then I will start the topic. So, maximum blood volume in the body is present in veins. Maximum blood volume is present in veins. Maximum cross-sectional area is of capillaries. There are arteries, veins, and capillaries. Veins have venules also. And most important blood vessel in inflammation is venules. All these three are important MCQs which are already asked in previous year exams. So you have to take these three MCQs. Maximum blood volume present in veins. Most important for inflammation, venules. And maximum cross-sectional areas of capillaries. Note it down, the three important points. Now I'm starting the first disease here. First I will tell you hypertensive arteriosclerosis. Then I will tell you atherosclerosis. Then I will tell you aneurysm. Then I will tell you aortic dissection. These four, and then vasculitis. So these 5 topics are important in blood vessels. We will take them one by one. Let's see how much we can cover today. Starting with the first one, hypertensive arteriosclerosis. What do you mean by hypertension? What do you mean by hypertensive arteriosclerosis? What do you mean by hypertension? Hypertension is elevation in blood vessel. So we have two components in blood vessel, systolic blood pressure and diastolic blood pressure. Normal blood pressure is 120/80. So here 120 is SBP, systolic blood pressure, and 80 is diastolic blood pressure. So if any one of them is raised, if systolic and diastolic, any one of them, the person is said to be hypertensive. So what is the classification of hypertension? So normal hypertension, systolic and diastolic. Systolic should be less than 120 and diastolic should be less than 80. It is known as normal. But if a systolic is between 120 to 140, this classification is important. And diastolic is between 80 to 90. The person is said to be pre-hypertension, not hypertensive. Person is said to be like there is pre-diabetes now. There's pre-hypertension. The person is having tendency to have developed hypertension in future, but still the person is not in hypertensive category. So by modifying the risk factors in the life, by modifying lifestyle, the person can be having normal blood pressure. So person is pre-hypertension. But if the person's systolic blood pressure is 140 to 160 and diastolic is 90 to 100, this is stage 1 hypertension. The person already entered hypertension, it is stage 1. And if it is more than 160 systolic and diastolic more than 100, it is stage 2 hypertension, stage 2. So this is the classification of hypertension. If any of the component is raised, either systolic or diastolic, it is known as hypertension. If any of the component is raised, what is the problem? बढ़ा है बढ़ने दो ना, उसे problem क्या हो रहा है? The raised blood pressure will cause end organ damage. The kidneys will be damaged, eyes will be damaged in a long run. There is hypertensive retinopathy, there is hypertensive renopathy. So end organ damage is there. So you already know all these things. Now hypertension have two components. Now you already know the formula for hypertension, blood pressure is cardiac output into peripheral resistance. You have already learned all this in physiology, so I'm not covering it. Here systolic blood pressure is controlled by cardiac output, and diastolic blood pressure is managed by peripheral resistance. You already know this. So I'm leaving the physiology portion and directly coming on the pathology portion. Yeah, one more thing. Malignant hypertension. Here stage 1 and stage 2 are known as benign hypertension. This is pre-hypertension. Usko to maan hi nahi raha hypertension. Stage 1 and stage 2 hypertension is known as benign hypertension. It is benign. And there is the term known as malignant hypertension. If the systolic blood pressure is more than 200 and diastolic is more than 120, so it is known as malignant. You can add it in this table only. Systolic more than 200 and diastolic more than 120. Systolic more than 160, it is stage 2. More than 200, it is malignant. Diastolic more than 120. 120 normal systolic होता है, लेकिन अगर systolic की जगह वो diastolic हो जाए, it is malignant. So learn this. So what is benign hypertension? What is malignant hypertension? You already know it. Done? Should I proceed? Should I proceed? So have you got it? What is benign hypertension? Stage 1, stage 2 is benign. What is malignant hypertension? Malignant is systolic more than 200 and diastolic more than 120. Now listen. What is pathology point of view? Why hypertension is important? So if a person is having hypertension, so he is having hypertension either benign or malignant. In benign, either stage 1 or stage 2. If the person is having benign hypertension stage 1, if a person is having benign hypertension stage 2, and if a person is having malignant hypertension, then these are the three pathologies we can see. These are the three pathologies we can see in their respective blood vessel. If a benign stage 1 person is dead, I am doing the autopsy. If I take a blood vessel, cut the blood vessel and make a slide of it, what I can see in the blood vessel is hyaline arteriosclerosis. I will show you the diagram of all three. This is the diagram of all three. So hyaline arteriosclerosis I will see. I will explain the diagram. If a person of benign hypertension stage 2 or malignant also, malignant in दोनों में होगा. The last two are for malignant. Or if a person with malignant hypertension is dead, I am doing the autopsy. I will cut the blood vessel. I will see it in the microscope. I can see hyperplastic arteriosclerosis or necrotizing arteriolysis. So you will find these three terms difficult, but once I will explain you the diagram of these three, the terms are really funny for you. So we will take them one by one. So the first term in these two it is benign. Benign में क्या होगा? Benign में ये होगा. And malignant में क्या होगा? Malignant में ये दोनों चीजें होंगी. So right here benign, right here malignant. Listen. What is happening? So first we will talk about the first term, that is hyaline arteriosclerosis. It is seen in benign moderate hypertension. Hyaline arteriosclerosis. What is the term? The term name itself indicate hyaline arteriosclerosis. So what is happening? Look at the first diagram. Hyaline arteriosclerosis. What you are seeing apart from normal, I have told you the normal diagram na, intima, media, externa. उसके अलावा क्या दिख रहा है? So you can see the red color intima here, the red colored cells. You can see a pericardia, media, and externa also. What extra you can find here? The pink colored material which I am marking with green. The pink colored structureless material here. The pink colored structureless material which is known as hyaline. So there is deposition of hyaline. Eosinophilic means pink colored structureless material. Where it is depositing? In the intima and media. So tell me what is shown in the diagram. Describe it. In the diagram, pink colored eosinophilic structureless hyaline material is deposited in intima and media, and it is known as hyaline arteriosclerosis because hyaline is deposited. That pink colored material is known as hyaline. Give me a thumbs up if you got it. So that is the first thing. So the name is hyaline arteriosclerosis. It is seen in benign hypertension. That is the first thing. This is a real diagram. So you can see the pink colored structureless material in the intima, in the media. The pink colored structureless eosinophilic material is known as hyaline. So that is seen in benign. That is seen in benign hypertension. Hyaline arteriosclerosis. Coming on the second one, very important. Hyperplastic arteriosclerosis. Again arteriosclerosis, but it is hyperplastic. What do you mean by that? It is seen in malignant hypertension, not in benign. It is seen in malignant. So see the diagram. See the second diagram now. Don't see the first, don't see the third. See the second diagram. See the second diagram. It is hyperplastic arteriosclerosis. So what is there? What is different than normal? I've told you the normal diagram. Na? What is different than normal? Can anyone tell? Can anyone tell me? What is different? The media, look at the media. In the media, look at the smooth muscle cells. The smooth muscle cells are more. The media is thickened. Look at the media, the smooth muscle cells. They are proliferating. They are proliferating in whorls. The smooth muscle cells here are proliferating in whorls. They are proliferating in laminated layers like an onion. Pyaz khaya hai? Have you cut the onion ever? When you cut the onion, you can see the layers of the onion. You can see the layers of the onion like laminated layers. or concentric layers. So here the media, the smooth muscle cells are proliferating like the layers in an onion in concentric layers known as laminated layers. So it is known as onion skin appearance. What is it is known as? It is known as, where it is? Just a second. Onion skin appearance. Take this word for MCQ. Onion skin appearance. So what is the definition of onion skin appearance? It is concentric layers or laminated layers of what? The layers are formed by what? By hyperplastic smooth muscle cells. Hyperplastic smooth muscle cells of the media. So that is malignant hypertension. It is known as hyperplastic arteriosclerosis because smooth muscle cells are showing hyperplasia and they are arranged in concentric layers. They are showing hyperplasia. That's why it is known as hyperplastic arteriosclerosis. So no need to learn the name, just understand. The first one was known as hyaline arteriosclerosis because hyaline was deposited. The second one is known as hyperplastic arteriosclerosis because hyperplasia of smooth muscle cells. So the name itself indicates what is the pathology. Pathology is a very simple subject. No need to learn pathology. Name itself indicates what is the pathology. You have to just understand the things beautifully. Correct or not? So that is the thing. So that is the second point. So coming on the third one, necrotizing arteriolitis. Now two terms are there. One is necrotizing, other is arteriolitis. Itis means, in pathology, the term itis means inflammation. So there is some inflammation. So there is inflammatory cells should be there in the diagram. And necrotizing means necrosis should be there. Now there are 5 types of necrosis. Whenever you talk about necrosis, you have to tell me the type of necrosis. So again, look at the third diagram now. Again, the third one is seen in malignant hypertension. So the second and third, both terms are in malignant. The first one is in benign. So hyaline is in benign, but the hyperplastic and necrotizing is in malignant. It is seen in malignant hypertension. Two things will be there, as the name indicates. Necrotizing means fibrinoid necrosis is there. There is 5 types of necrosis: coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis. The 5th one is fibrinoid necrosis. Now go in the general pathology, read necrosis there. Open fibrinoid necrosis. Look at the examples of fibrinoid necrosis. You will find this there. So fibrinoid necrosis, just read it like correlating everything with each other. So fibrinoid necrosis is there in the walls of the blood vessels. It is there in the example there. So just open the Robbins there also. So fibrinoid necrosis is there. Number 1, I will show you in the diagram. And acute inflammatory infiltrate of neutrophils in the adventitia. That is outermost layer. So middle layer, medium in necrosis. Now look at the third diagram. You have to tell me 2 things. One is necrosis and other is neutrophils. Inflammation means neutrophils. So look at the third diagram. Just try to see, to focus on 2 things. Can you see neutrophils? PMN means neutrophil. Can you see all these neutrophil I'm marking? Multilobated cells, neutrophils there. Yes, you can see. And now with green, I'm marking the necrosis. The structureless pink material dot in between. The structureless pink colored dots in between. That is fibrinoid necrosis. So 2 things, fibrinoid necrosis and neutrophils. Say yes or no. So it is known as necrotizing because fibrinoid necrosis is there. Arteriolitis because neutrophil inflammation is there. Say yes or no. So that is the third thing. So we are done with the 3 things. Number 1, hyaline arteriosclerosis, which is seen in benign hypertension, in which hyaline structureless eosinophilic material is deposited in intimate media. And number 2 and 3, hyperplastic and necrotizing arteriosclerosis, these 2 are seen in malignant hypertension. So any doubt in this? Any doubt? Will you be able to draw these 3 diagrams? Any doubt in this? Should I proceed? Give me a thumbs up if done. Any doubt? Please write. Should I launch polls based on hypertensive pathology? So from pathology point of view, hypertension is important that much. Hypertension is an extensive topic. I will teach you hypertension in pharma also. Antihypertensive drug I will teach you. I will teach you hypertension in medicine also. So hypertension you have red blood pressure in physiology also. So hypertension you have to study in multiple subjects. But for pathology point of view, this is important. The 3 terminologies you have to learn: hyaline arteriosclerosis, hyperplastic arteriosclerosis, necrotizing arteriolitis. The first one is in benign hypertension, rest 2 are in malignant hypertension. And you should be able, if you are a second prof student, you should be able to draw these 3 diagrams. for your second paper 2, for paper 2 of pathology. It is a very important 5-mark or 3-mark question which comes in your exam. So you should be able to draw this with your pink, purple and lilac pencil. You know how to use these pencils judiciously. Don't use any color, any other color. Use these colors only. If I am the examiner, I give marks to student if these colors are used. If you use red, orange, everything, I won't give the marks. No examiner will give the marks. So in paper 2 of pathology, you have to use only these 3 pencils. It is a rule. It is not my suggestion. It is a rule. So you have to draw all these histological diagrams with pink, purple, lilac pencils. Don't use any other. You can use red in small amount. So that is the thing. So have you got it? Should I proceed? So this is the first MCQ in front of you. This is the first MCQ. Now this is a tricky one. This is a tricky one. Yes. So read it out. I'm sorry. Read it out. Major change occurring in blood vessels and hypertension. Now the trick in the question, in hypertension, I have not written benign or malignant. Question is wrong, you can say. Question should contain benign or malignant because options contain both things. If I say benign, your answer will be different. If I say malignant, your answer will be different. So there are 2 options correct here. So those who have marked B, they are correct. Those who have marked D, they are also correct. So 2 answers are correct here. B is also correct. D is also correct. Now let me ask specifically. I shouldn't launch this poll. Let me ask specifically. So major change occurring in blood vessels in benign. If I say benign hypertension, what will be your answer? Write in chat box. I'm not launching it again. If I say benign hypertension out of 4 ABCD, what will be your answer? So Udit, Soham, you all are correct. Dipti, Jaydev, Deepak. Okay, you all are correct. Sanjana, so the correct answer will be B. If I am asking benign hypertension. If instead of benign, I am asking malignant, then major change occurring in blood vessels in malignant hypertension, then what will be your answer? Then yes, everyone got it. Then in that case, the correct answer here is D. So I have told you in benign hypertension, it is hyaline arteriosclerosis. In malignant hypertension, it is fibrinoid necrosis or necrotizing arteriolitis. One and the same thing, na? Necrotizing arteriolitis mein ho to fibrinoid necrosis hi raha hai na? So it is D. So correct answer is D in that case. So correct answer B, D, dono sahi hai. Both are correct. So no need to share leatherboard here. Correct or not? So B and D both are correct. This is the second question in front of you. What is the most common histological finding in benign hypertension? In benign hypertension, I'm just launching it. Commonest histological finding in benign hypertension. So all of you are correct. I'm very happy. All of you are correct. So correct answer here is, of course, the correct answer here is C. It is hyaline arteriosclerosis. So correct answer here is C, hyaline arteriosclerosis. So Arjun, Lakshmi and Srishti are first to answer. So in benign, it is, So correct answer here is C. So this is the next question. In malignant hypertension, what is the pathology? Yes. In malignant, what is the pathology? Just read the options and choose the most correct one. Read the options and choose the most correct one. In malignant hypertension, what is seen? Yes. So most of you are correct. I am happy you got my concept. So correct answer here is B. Replacement by necrotizing arteriolitis in malignant one. So Lakshmi, Arjun and Udit are first to answer. So correct answer here is B. Great. Great. This is the next question. Onion skinning is seen in. Yes. What is the answer? Onion skinning. Okay, I have not launched it. Onion skinning किसमें होता है? Benign में कि malignant में? Onion skinning किसमें होगा? Onion skinning is seen in hyperplastic arteriosclerosis. So hyperplastic arteriosclerosis benign hota hai ki malignant hota hai? It is seen in malignant. The first one is benign, rest two are malignant. So only 75% of you are correct. 25% have marked as benign. Benign is not the correct answer. Malignant is correct answer. So correct answer here is A. Lakshmi, Sushma and Samarth are first to answer. Great. Good. So correct answer here is A. So I am done with it. Are you people done? Ready? Next 10 minutes more for atherosclerosis. Want me to complete or should I take it in the next lecture? You have 10 minutes more. Should I finish the topic? Okay, done. You are not bored yet. Okay. If you're not bored, okay then. Enjoying, happy, good. So atherosclerosis. Again, I'm specifically teach you here the pathogenesis of atherosclerosis. So what is atherosclerosis? In atherosclerosis, there is thickening and hardening of the arteries There is involvement of intima. The most common layer involved in atherosclerosis is intima, not media, not externa. It is intima, not media, not externa. Intima is involved. So a fibrofatty plaque is formed which protrude in the blood vessel. This is a normal blood vessel. This is the lumen of the blood vessel. This is the lumen. See here, in the lumen of the blood vessel, a fibrofatty plaque is formed, which is protruding in the lumen and narrowing the lumen. This is known as atherosclerosis. What is the composition of this? How it is formed? What are the steps of its formation? That is important. How it is formed? What are the steps of its formation? And what is the composition? That is important. So it is a fibrofatty plaque or atheroma that is protruding in the lumen, narrowing the lumen. So how it is formed? So there are multiple steps. There are multiple steps by which it is formed. I will tell you the 4 steps. I will tell you the 4 steps. And ultimately it is formed like this. It is protruding in the lumen, narrowing the lumen. And see the composition. I will tell you the composition also. What are the most common arteries involved by atherosclerosis? Have you got what is atherosclerosis? It is a fibrofatty plaque which arises from intima, not media, not externa. It is arise. This is a blood vessel. Intima, media, externa. So from intima, it is arising and protruding in the lumen, narrowing the lumen. It is a fibrofatty plaque. That is a simplified definition. What are the most common sequence of arteries? We have various arteries in the body. Na? Most common artery involved by atherosclerosis. What is most common? What is second most common? Third most common? You should know the sequence. So most common artery involved is abdominal aorta. Second most common is coronaries artery. Coronary में भी क्या sequence है? You know the 3 coronaries. I have taught you last lecture. Those who have attended my last lecture, they know the 3 types of coronary: LAD, RC, and LCX. This is the sequence in coronaries. The third most common is popliteal. Fourth is descending thoracic. Fifth is internal carotid. And sixth is cerebral arteries or circle of Willis. So you should know the sequence. Now, I should give you a mnemonic now. It is a complicated one. How you will learn? So there is a mnemonic for it. So mnemonic is ACP of Delhi traffic is cute. So mnemonic is also cute. Now, ACP of Delhi traffic is cute. ACP. A से abdominal aorta, C से coronary artery, P से popliteal. ACP. Off से कुछ नहीं है. Delhi का D. Delhi का D means descending thoracic. Traffic. Delhi का D हो गया. फिर traffic. ट्रैफिक से भी कुछ नहीं है. अच्छा, दिल्ली ट्रैफिक DT से डिसेंडिंग थोरेसिक. DT दिल्ली ट्रैफिक डिसेंडिंग थोरेसिक. इज का I is internal carotid and cute का C is circle of Willis. Have you got the mnemonic? ACP of Delhi traffic is cute, so that is the mnemonic. So abdominal aorta, coronary, popliteal, descending thoracic, internal carotid, and circle of Willis. So wherever it is possible, and I know the mnemonic, I will share it with you. So it is easy to study with the mnemonics. Now I suggest you, if you are a second prof student, make a big notebook, a big register, and list all the things together, all the mnemonics together. Divide the notebook, a big thick notebook, in multiple parts. All the pathognomonic features together, all the most common together, all the scientists together. So make multiple lists from day 1 only. So till you reach your final year now, that notebook will be completely written by your hand, and you will have multiple list annexures with you. So all the books will give you annexures, but the most important which you make by yourself, you will never forget. And at the last day of your exam, just revise that notebook. So make a notebook, start making list by today only. So all the mnemonics you should write together, all pharma mnemonics together, medicine together, that you can subject wise, you can also divide, or at the end, no subject matters. 300 questions matters. 300 questions, you have to attempt it correctly and in speed. So that is the important thing. Subject doesn't matter. कौन सा question किस subject से कब क्या, कुछ फर्क नहीं पड़ता. You have to attempt 300 questions at that day. Correct or not? So that is the thing. So etiology, I'm just leaving the etiology. I'm coming on the pathogenesis. So Aditi is asking how to differentiate atherosclerosis and arthritis. Two are separate, very separate things, Aditi. Arthritis means inflammation. Atherosclerosis is not inflammation. I'm telling you, no, atherosclerosis is a plague. It is a fibrofatty tissue which is protruding in the lumen. There is no inflammation in that. So two things are different. I'm skipping this one. I'm coming on the pathogenesis, which is important to explain. Risk factors, you can read it by yourself. So pathogenesis, how atherosclerosis occurs. How atherosclerosis occurs, that is important. Now there is a phenomenon which is known as reaction to injury. Reaction to injury hypothesis. I will explain you this hypothesis. Reaction to injury hypothesis. This is a 3-mark or 5-mark question for second prof. What is reaction to injury hypothesis? How atherosclerosis is formed. Now listen it like a movie story. I'm telling you a story of a movie. So listen like this. So there are 4 steps. What are the 4 steps? I will tell you one by one. So first step is endothelial injury. Injury is to the endothelium. You know the 3 layers. You know the 3 layers. Now you can see this diagram. This is intima. This is endothelium. This is endothelium or intima. This is all media and this is externa. So blood is present. Blood is present in the lumen. That blood contains something which is causing injury to the endothelium. So first step is injury to endothelium. For causing atherosclerosis, there should be injury to the endothelium first. That is the cornerstone for the development of atherosclerosis. That injury can be caused by any poison, anything which is present in the blood, any organism present in the blood, cholesterol or lipid present in the blood. So anything present in the blood is causing to the injury to the endothelium. That is the first step. Injury to the endothelium. So any etiological culprit which is present in the blood, which is present in the lumen, it is causing endothelial injury. Number 1. So once endothelium is injured, it is activated and it will secrete TNF, tumor necrotic factor. So endothelium will secrete TNF and TNF causing increased expression of VCAM, vascular endothelial factor, VCAM on the endothelial cells. VCAM will be expressed and it will cause increased permeability to the endothelium. What do you mean by that? And lipoprotein or lipid which is present in the blood will enter inside. So what do you mean by that? So can you see this diagram? These diagrams are from Robbins. So I suggest you personally to read only Robbins and draw all diagrams from Robbins only in your exam. Some diagrams from Hirschman are also I find good, so I share that also, but Robbins should be your main book. So you can see this diagram, you can see the lumen. Can you see this lining? Can you see these cells? These are endothelial cell lining. I'm marking with purple. So these are endothelial lining. From endothelium, behind endothelium, there is media and there is externa. You can see smooth muscle cells in the media and you can see the externa. So you can see this is the lumen. So from lumen, there is injury to the endothelium. Once there is injury to the endothelium will secrete TNF in the blood, tumor necrotic factor. And because of this TNF, there is increased expression of a receptor on the endothelium. There is an expression of a receptor. That receptor is known as VCAM. Vascular, it is vascular adhesion molecule. VCAM is expressed on the cells. Once VCAM is expressed on the endothelial cells separate from each other, and between the endothelial cells gaps will be formed. Holes will be formed between the endothelial cells. Gaps abhi ek dusre se attached hai, there is no gap, but once VCAM is present on this, they will separate from each other and gap will be formed in the endothelium. That is known as increased vascular permeability. Permeability is increased. Now the fat which is present in the blood fat is present. Now lipid is present, cholesterol is present, that will enter from that gap inside. So inside the wall, that fat is entering. So that is endothelial injury. So can you see these yellow colored dots? I'm marking with purple. These yellow colored dots are present in which layer? Can anyone tell me? Yellow colored dot yani fat ghus gaya. Fat andar chala gaya. Fat has entered inside. In which layer? Which is this layer? Yes, intima. You all are right. Intima ki second layer hai. Kaun si layer? Subendothelium. So intima ki first layer is the endothelial cell. Just behind the endothelial cell, there is subendothelium which is made up of collagen. Usme ghusa hai fat. Media में नहीं गया है. Media is this brown color. Media में नहीं गया है. Externa में नहीं गया है. Intima में ही है. So fat has entered inside intima. So atherosclerosis is a disease of intima. Again, an important MCQ. Correct or not? So this is the diagram. So you can see the fat has entered inside. You can see this diagram also. Can you see this cholesterol is entering? Yellow colored cholesterol. Fat is entering. There is a gap between these two cells. So please just zoom it out. See the gap between the two endothelial cells. Fat is entering inside. See the yellow colored fat entered inside in the intima. Till now we have done with the first step. What was the first step? Injury to the endothelium. Endothelium को injury हुई, वो activate हुआ. TNF is secreted. Because of TNF, VCAM expression is there. Because of VCAM, endothelial cells separated, permeability increased, and lipid entered inside from the lumen, from the blood into the subendothelium. And lipid is deposited inside subendothelium. Till now it is okay. Should I proceed? The second step, migration of the leukocytes. Now blood contains 5 types of WBC. Now what are the 5 types of WBCs? Granulocytes and agranulocytes. What are the 3 types of granulocytes? Neutrophil, eosinophil, basophil. What are agranulocytes? Lymphocytes and monocytes. Monocytes will enter. So out of the 5 type of WBC, monocytes present in blood will enter from that gap. अभी उस gap से कौन घुसा? अभी उस गैप से कौन घुसा था? कोलेस्ट्रॉल. नाउ उस गैप से मोनोसाइट विल एंटर. सो वीकैम तो अभी भी एक्सप्रेशन है ऑन द सेल्स ऑफ द endothelium. VCAM is present, so they are separated, so gap is there. From that gap lipid already entered. Now from that gap monocyte in the blood, all WBCs are present. No, not all will enter. Monocyte will enter inside. Once monocyte leave the blood and enter the tissue, once monocyte leave the blood and enter in the intima, in the tissue, it is known as macrophage. So it is known as macrophage now. So macrophage is nothing but modified monocyte only. So monocyte will get converted into macrophage. Monocyte will go in the subendothelium intimal space. वहीं पे गया intima में, media में नहीं गया है, and it is getting converted into macrophage. So see this diagram, a beautiful diagram from Hirschman. Beautiful diagram. So can you see a blood vessel? Yes, you can see. Can you see a monocyte here? Yes. So monocyte, can you see a gap between these two cells? Yes. So monocyte is entering through this gap and going behind, going in the wall. So going in the wall, this monocyte get converted into macrophage. Monocyte get converted into macrophage. So यहाँ पे पहले से fat पड़ा ही था. Fat was already there. Fat was already there in the space, and now monocyte also entered. Macrophage also entered there. That macrophage will eat that fat. That fat will be eaten. That fat, first macrophage convert that LDL. There is LDL, HDL. Now that LDL get converted, low density lipid will get converted into oxidized LDL. So oxidized LDL is eaten by this macrophage, and this macrophage is known as foam cell. Can you see? This macrophage has eaten all the oxidized LDL and get converted into foam cell. Say yes or no. See this diagram, beautiful diagram. Give me a second, just a second. My time is over, I guess. Let me extend it. Okay, I've extended. So can you see it? Endothelial layer is there. So from one gap, lipid is entering. From other gap, monocyte is entering. After entering inside, monocyte get converted into macrophage. This macrophage converting this fat, the yellow colored fat, this fat into oxidized LDL. After converting, it is eating it. It is engulfing it. And can you see these macrophages, the yellow colored dots inside the macrophages? Now this macrophage with yellow colored dots inside is known as foam cell. So macrophage get converted into foam cell. So that activated macrophage will oxidize the LDL and form oxidized LDL. And after forming oxidized LDL, it will ingest it. And once it will ingest it, it is known as foam cell. Tell me the story. Have you got it? So this macrophage will eat the fat and known as foam cell. Which fat? Oxidized LDL. LDL को oxidize कौन करेगा? यही करेगा. Macrophage ही करेगा. So that is known as foam cell. So that is the second step. Now see here, again I am revising. This is endothelial injury. VCAM is expressed. Permeability is increased. Fat will enter inside. Macrophage will also enter inside. After entering inside, it will get converted into macrophage and eat the fat and get converted into foam cell. Coming on the third step. Smooth muscle proliferation from the media. In media, smooth muscles are present. Can you see? The brown colored layer here? Media. In media, smooth muscles are present. Smooth muscle cells, brown colored cells present in media will leave media and come in intima. They are seeing. Can you see? They are leaving it. They are migrating. They are migrating the media and coming in the intima. So migration of smooth muscle cell from media to subendothelial intima. That is the biggest step. Once they will come, they will also eat fat. And they are not known as foam cell. They are known as fat containing smooth muscle cells. They will also eat fat. So see this diagram. In the media, in the subendothelial space of media, you can see two types of cell. You can see macrophages, you can see smooth muscle cell. Macrophage lumen में से आया, smooth muscle cell media में से आया. एक ऊपर से आया, एक नीचे से आया. दोनों आके accumulate होके fat खा के बैठ गए. So smooth muscle cell as well as macrophage both have engulfed the fat and get converted into foamy cells. Say yes or no. Have you got it? Give me a thumbs up if you got it. So that was the third step. And last step is maturation of the plaque. What will happen? More fat and fat will enter, and that fat will accumulate at the center. So center contains fat and periphery contains the cells. Two types of cells. Macrophages which are coming from the lumen, monocytes coming from the lumen, and smooth muscle cells coming from the media, and both of them have engulfed the fat. And fat is present as a core at the center also. So that is maturation of the plaque. So that are the four. So can you see at the center there is a yellow colored core, that is fat. And at the periphery, there are two types of cells, macrophages and smooth muscle cells. Both have engulfed the fat. So that is the summary. So the 4 steps. Can anyone help me in revising the 4 steps? Yeah, fast. I don't have the time. I have already extended the class. Yes. The first step is endothelial injury. Can you see the endothelial injury? Say yes or no in this diagram. Endothelium is injured. So what is the response to injury? Who will tell me? As soon as endothelial injury is there, VCAM expression is there. VCAM expression is there. Endothelium will separate. Permeability will increase. Fat will enter inside. After that, the second step is migration of the leukocytes or monocyte. So can you see monocyte is entering inside? Monocyte entering inside, they will get converted into macrophage. Macrophage will engulf the fat, convert into foamy cells, and oxidize LDL, form oxidized LDL and accumulate there. And then smooth muscle cells will leave the media and come in the intima, and they will also engulf the fat. And lastly, maturation. Last step is maturation. Have you got it? So ultimately, atherosclerotic plaque is formed. Just a second. Give me a second. So I have done the pathogenesis. You can read the morphology by yourself, and MCQs are also there, but time is not allowing me to launch the polls based on this topic, but it is given in my notes. You can download the notes anytime. Many students are asking notes to me. I can send you the PDF separately also if you can ask me on a subscription for that. So just share this information with everyone. And tomorrow I'm going to take renal system. Very, very important. I will start with glomerulonephritis. Very important. 5-star important. Don't dare to miss it. And share this information on their batch groups. Please follow my profile link on Unacademy. Search by my name. My name is Dr. Priyanka Sachdev. Please search it by my name and follow my profile. You will get notification of all my free classes. My code is Sachdev10, SACHDEV. That is my name, Dr. Priyanka Sachdev10. You can use this code, share this code with your batchmates to unlock the free classes. You can share this code with everyone to unlock the free classes. You can also take plus subscription. You will get 10% discount if you wish. It is not compulsory. If you want, you can take the subscription and use this code. See you tomorrow at 10 a.m. in the morning. Study hard till then. Okay. Bye-bye. See you.